വേറെ എന്തെങ്കിലും ചോദിക്കാനുണ്ടെങ്കിൽ
you have to monitor, you have to be aware of the subdivisions. അത് ഭയങ്കര ഇമ്പോർട്ടൻ്റ്. അപ്പോൾ ആകെ 5 പേജ് ഉണ്ട്. 5 പേജിൽ മാർക്ക് അനുസരിച്ച് എഴുതണം. അപ്പോൾ അതനുസരിച്ച് നിങ്ങൾക്ക് you should think for 1 minute and then write. നേരെ എഴുതി തുടങ്ങി പണി കിട്ടാൻ ചാൻസ് ഉണ്ട്. ഓക്കെ. രണ്ടാമത്തെ കാര്യം, ക്വസ്റ്റ്യൻ പല രീതിയിലും പല വിഭാഗത്തിലും വരും. ബട്ട് ഐ തിങ്ക് 3 വർഷത്തെ DRMB കഴിഞ്ഞ ശേഷം നിങ്ങൾക്ക് അറിയാൻ പാടില്ലാത്ത ഒരു ടോപ്പിക് വരാൻ ചാൻസ് ഇല്ല. ഒറ്റ നടത്തിൽ നിങ്ങൾ വായിക്കുമ്പോൾ നിങ്ങൾ കേട്ടിട്ടില്ല വായിച്ചിട്ടില്ല എന്ന് നിങ്ങൾക്ക് തോന്നുമായിരിക്കും. പക്ഷേങ്കിൽ ഇഫ് യു ഡോണ്ട് പാനിക് ആൻഡ് ഇഫ് യു തിങ്ക് എ ബിറ്റ് ഫോർ 1 minute യു ഷുഡ് ബി ഏബിൾ ടു റൈറ്റ്. അതാണ് രണ്ടാമത്തെ കാര്യം പറയാനുള്ളത്. പാനിക് ചെയ്യാതെ എഴുതാന്നുണ്ടെങ്കിൽ നിങ്ങൾക്ക് കിട്ടും എന്ന് എനിക്ക് തോന്നുന്നു. ആൻഡ് തേർഡ് തിങ് ഇസ്, പരീക്ഷ തലേന്ന് നിങ്ങൾക്കൊന്നും പഠിക്കാൻ പറ്റത്തില്ല. അത് ഓർത്ത് നിങ്ങൾ ബോധർ ചെയ്യാൻ വേണം. പരീക്ഷ തലേന്ന് മര്യാദയ്ക്ക് ഉറങ്ങി സമയത്ത് പോകാൻ നോക്കുക. ഈസി അല്ല, ബട്ട് ഇറ്റ് ഈസ് പോസിബിൾ. പരീക്ഷ തലേന്ന് നമ്മൾ എക്സ്ട്രാ എഫേർട്ട് ഇട്ട് ഉറക്കളച്ച് രാവിലെ ലക്ഷ്യം പിടിച്ചു പോകേണ്ട കാര്യമൊന്നുമില്ല. ട്രൈ ടു ബി കാം. അത് പരീക്ഷ തലേ ദിവസം മുമ്പ് തന്നെ നിങ്ങൾ തുടങ്ങുക. ബിക്കോസ് യു കൻ ടേക്ക് അവർ വേർഡ് ഫോർ ഗ്യാരണ്ടി. ആ ദിവസം പഠിച്ച് നിങ്ങൾക്കൊന്നും കിട്ടാൻ വരാൻ പോകുന്നില്ല. What matters is what you have studied over the past 3 years and what you gained from this course. അതൊക്കെ ആയിരിക്കും മാറ്റർ ചെയ്യാൻ പോകുന്നത്. So you don't be stressed enough. You will do good. You can do good. Okay. അത് മാത്രമേ ഉള്ളൂ.
പ്രാക്ടിക്കൽ വേണ്ടല്ലോ, തിയറി അല്ലേ. എങ്ങനെ
ആൻസർ പേപ്പർ സബ്ഡിവിഷൻസ് ഇല്ല.
ഇല്ല. അത് DRMB യൂഷ്വലി അവരുടെ ഡിവിഷൻ എന്ന് പറഞ്ഞു കഴിഞ്ഞാൽ ഫസ്റ്റ് പേപ്പർ ഫിസിയോളജി, സ്റ്റാറ്റിസ്റ്റിക്സ്, അനാറ്റമി, സെക്കൻഡ് പേപ്പർ പ്യൂർ ക്ലിനിക്കൽ, തേർഡ് പേപ്പർ റീസെന്റ് അഡ്വാൻസ് ട്രയൽസും ആണ്. പക്ഷേ ഇതാണ് ഞങ്ങളുടെ തേർഡ് പേപ്പർ. പക്ഷേ ഇതിൻ്റെ അകത്ത് ഒരു ട്രയലും ഇല്ല, ഒരു റീസെന്റ് അഡ്വാൻസസും ഇല്ല. അപ്പോൾ നമ്മൾ മറ്റേ അപ്ഡേറ്റ്സ് ഐഡിയലി 2023, 24, 25 അപ്ഡേറ്റ്സ് ഒക്കെ വായിച്ചിട്ട് പോകണമെന്ന് പറഞ്ഞാൽ നമ്മളതെല്ലാം വായിച്ചിട്ടായിരിക്കും പോകുന്നത്. പക്ഷേ അതിൽ നിന്ന് ഒരു ക്വസ്റ്റ്യൻ പോലും ചോദിച്ചില്ല. പക്ഷേ ചില ഫസ്റ്റ് പേപ്പറിൽ ചില ക്വസ്റ്റ്യൻ ഉണ്ടായിരുന്നു. അപ്പോൾ അത് മാറി മാറി വരും.
നമ്മൾ പ്രൊഫഷണൽ നമ്മൾ MD കഴിഞ്ഞ് അടുത്ത ലെവലിലേക്ക് പോവുകയാണ്. സോ യു ഷുഡ് ബി പ്രിപ്പയർഡ് ടു ആൻസർ MD. പേഷ്യന്റ് നമ്മൾ പറഞ്ഞിട്ടല്ല വരാൻ പോകുന്നത്. അല്ല, പേഷ്യന്റ് പല രീതിയിൽ പല ഭാഗത്തിലും വരും എന്ന് പറയുന്ന പോലെ ക്വസ്റ്റ്യൻ ഞാൻ കമ്പനി എനിവേ യു ക്യാൻ ആൻസർ ഇറ്റ്. നിങ്ങൾ പാനിക് ആകുമ്പോൾ നോക്കിക്കഴിഞ്ഞാൽ യു വിൽ ബി ഏബിൾ ടു ആൻസർ ഇറ്റ്. മാത്രമേ ഉള്ളൂ, വേറെ ഒന്നുമില്ല. ആൻഡ് അഗെയിൻ ഐ ഡോണ്ട് തിങ്ക് അഗെയിൻ നിങ്ങൾ പരീക്ഷയ്ക്ക് പഠിക്കുന്നതിനേക്കാളേറെ ലേൺ ടു ഇൻക്രീസ് യുവർ നോളജ്. നാളെ പരീക്ഷയ്ക്ക് അത് ഉപകരിക്കും, ഭാവിയിലും അത് ഉപകരിക്കും. സോ ഹാവ് പാഷൻ ടുവേർഡ്സ് ലേണിംഗ് ആൻഡ് റീഡിംഗ് ആൻഡ് ലേൺ ടു ഇൻക്രീസ്. പരീക്ഷയ്ക്ക് പഠിക്കാതെ ലേൺ ടു ഇൻക്രീസ് യുവർ നോളജ്. ദാറ്റ് വിൽ ഹെൽപ്പ് യു ഔട്ട്.
പിന്നെ കുറച്ച് ഷോർട്ട് നോട്ട്സ് ഒരു ലാസ്റ്റ് മിനിറ്റ് വായിക്കാൻ വേണ്ടിയിട്ട് ഉണ്ടാകുന്നത് നല്ലതാണ്. കാരണം ഈ പ്രോട്ടോകോൾസ് ഒക്കെ, സ്പോർട്സ് പ്രോട്ടോകോൾ, സ്പൈക്സ്, എത്തിക്സ്, കാരണം അതെല്ലാം എപ്പോഴും നമ്മൾ മറന്നു പോകും. ഇനിയിപ്പോൾ ഈ ലാസ്റ്റ് ചിലർക്ക് ഷോർട്ട് ടേം മെമ്മറി ആയിരിക്കും. ഇപ്പോൾ ഞങ്ങളെല്ലാം ഭയങ്കര ഷോർട്ട് ടേം മെമ്മറിക്കാരാണ്. അപ്പോൾ നമ്മൾ ലാസ്റ്റ് മിനിറ്റ് എന്താ വായിച്ചുകൊണ്ട് പോകുന്നത് അത് നമുക്ക് അതുപോലെ റീപ്രൊഡ്യൂസ് ചെയ്യാൻ പറ്റും. പണ്ട് മുതലേ MBBS മുതലേ നമ്മൾ അതാ ഫോളോ ചെയ്തത്. അപ്പോൾ ചിലർക്ക് ഇപ്പോൾ ജേക്കബേട്ടനൊക്കെ അത് വേണ്ടായിരിക്കും, നേരത്തെ പോയാൽ മതിയായിരിക്കും. പക്ഷേ ഈ ഷോർട്ട് ടേം മെമ്മറി ഭയങ്കര ഇമ്പോർട്ടൻ്റ് ആണ്. കാരണം ഇപ്പോൾ 3 പേപ്പറിലും 3 ദിവസവും നമ്മൾ സെയിം സാധനങ്ങൾ പിന്നെ വായിച്ചുകൊണ്ട് പോയാലേ നമുക്ക് അടുത്ത പേപ്പറിൽ അത് റീപ്രൊഡ്യൂസ് ചെയ്യാൻ പറ്റുള്ളൂ. കാരണം ഫസ്റ്റ് പേപ്പർ ചോദിച്ച സാധനം ചെന്നാൽ ചിലപ്പോൾ സെക്കൻഡ് പേപ്പർ ചോദിക്കും. പക്ഷെ അത് തലേന്ന് വായിച്ചില്ലേ നമുക്ക് സെക്കൻഡ് പേപ്പർ റീപ്രൊഡ്യൂസ് ചെയ്യാൻ പറ്റത്തില്ല. കാരണം ടൈമാണ് അവിടെ ഇമ്പോർട്ടൻറ്റ്. നമുക്ക് ആലോചിച്ച് എഴുതാൻ സമയമില്ല. എന്താണ് മനസ്സിൽ വരുന്നത് അപ്പോൾ എഴുതി തീർക്കുക. കാരണം അടുത്ത ടൈം അവിടെ പോയി കഴിഞ്ഞാൽ അടുത്ത ക്വസ്റ്റിന് ടൈം കിട്ടില്ല. ഫുൾ 10 ക്വസ്റ്റ്യൻ എഴുതിയാലേ മാർക്കും കിട്ടുള്ളൂ. ഇല്ല, അത് അവിടെ ടൈം വരും, സിസ്റ്റത്തിൽ ടൈം വരും. റിപ്പീറ്റ് ക്വസ്റ്റ്യൻസ് വരും, അത് യൂഷ്വലി വരും. പക്ഷെ അത് കറക്റ്റ് റിപ്പീറ്റ് ആവണമെന്നില്ല. നമ്മൾ കവർ ചെയ്യുന്ന എല്ലാ ഏരിയയും കവർ ആവും. പക്ഷെ മോസ്റ്റ് ഇമ്പോർട്ടൻറ്റ് ഈ ഷോർട്ട് നോട്ട്സ് ആയിട്ട് പഠിക്കും. ഇപ്പം നിങ്ങൾ അടുത്ത DRMBക്ക് പോകുന്നവരാണെങ്കിൽ ഇതുപോലെ ഒരു നോട്ട് ഉണ്ടാക്കിയിട്ട് ഓരോ സിസ്റ്റമായിട്ട് വേണമെങ്കിൽ ഒരു 6 ഒരു ചെറിയ നോട്ട് എടുത്തിട്ട് ഓരോ സിസ്റ്റമായിട്ട് ചെറിയ ചെറിയ ഷോർട്ട് നോട്ട്സ് ആയിട്ട് എഴുതി. ഇപ്പം ഇഷ്ടംപോലെ മറ്റേ ഇതുപോലത്തെ ക്ലാസ്സുകൾ ഇഷ്ടം പോലെ ഉണ്ട്. അപ്പോൾ അവരെല്ലാം ഇപ്പോൾ അങ്ങനെയാണ് ഫോളോ ചെയ്യുന്നത്. ഓരോ സിസ്റ്റമായിട്ട് നോട്ട് കവർ ചെയ്ത് പോവുകയാണ് ചെയ്യുന്നത്. അപ്പോൾ അതാകുമ്പോഴത്തേ നമുക്ക് ലാസ്റ്റ് മിനിറ്റ് റിവിഷൻ ഭയങ്കര എളുപ്പമായിരിക്കും. കാരണം എന്ത് ലാസ്റ്റ് മിനിറ്റ് പഠിക്കുന്നോ അതേ നമുക്ക് റീപ്രൊഡ്യൂസ് ചെയ്യാൻ പറ്റുള്ളൂ. അതാണ് DNB എന്ന് എനിക്ക് മനസ്സിലായത്. ഇപ്പോൾ ഞാൻ അനസ്തീഷ്യയും DNB ആയിരുന്നു. എന്താണ് കാരണം പാടായിരിക്കും. കാരണം ഓർത്ത് എഴുതാനുള്ള ഭയങ്കര പാടാണ്. ഇപ്പോൾ അപ്നിയ ടെസ്റ്റ് നമുക്ക് സ്ഥിരം ചെയ്യുന്നതാണെങ്കിലും പക്ഷെ അത് എഴുതുന്നൊരു വിധമുണ്ട്. കാരണം ചുമ്മാ അപ്നിയ ടെസ്റ്റ് എഴുതിയിട്ട് കാര്യമില്ല, മാർക്ക് തരത്തില്ല. കാരണം എൻ്റെ ഫാറ്റിന് നമ്മൾ അപ്നിയയുടെ സ്റ്റെപ്പ് മാത്രം എഴുതിയിട്ട് അവർ 1 മാർക്കേ തന്നുള്ളൂ 5-ൽ. കാരണം അതിലും മറ്റേ പ്രീ റിക്വസ്റ്റ് എഴുതണം, അപ്നിയയുടെ എങ്ങനെയാണ് ചെയ്യുന്നതെന്ന് എഴുതണം, അതിൻ്റെ പോളിസി എഴുതണം, എങ്ങനെ അപ്നിയ ഫെയിലായി കഴിഞ്ഞാൽ എങ്ങനെ ഇത്, അതാണ് അവർ ഉദ്ദേശിക്കുന്നത്. അപ്പോൾ ആ 4 പോയിന്റ്സും ഒക്കെ ഉണ്ടെങ്കിലേ അവർ മാർക്ക് ഇടുകയുള്ളൂ. നമ്മൾ വിചാരിക്കും നമ്മൾ അപ്നിയ എഴുതി എന്തുകൊണ്ട് മാർക്ക് കിട്ടിയില്ല. പിന്നെ ഇത് പോകുന്ന ആൾക്കാരും പോകുന്ന സ്റ്റേറ്റും അനുസരിച്ച് ഡിഫറും ചെയ്യും. ചില സ്റ്റേറ്റിൽ ചിലർ ഇഷ്ടംപോലെ മാർക്ക് ഇടും, ചില സ്റ്റേറ്റിൽ ആരും മാർക്ക് ഇടത്തില്ല. അപ്പോൾ അങ്ങനത്തെയൊക്കെ പ്രശ്നങ്ങളുണ്ട്. പക്ഷേ യൂഷ്വലി ഫസ്റ്റ് ഇയർ കഴിഞ്ഞിട്ട് സെക്കൻഡ് ഇയറും തേർഡ് ഇയറിലൊക്കെ പാസ് പെർസെൻറ്റേജ് ഭയങ്കര കൂടുതലാണ്. കാരണം നമ്മൾ സാമാന്യം പഠിച്ചിട്ടുണ്ടെങ്കിൽ എല്ലാവരും പാസ്സാവും. ഒട്ടും ഒന്നും വായിക്കാതെ പോകുന്നവർ മാത്രമേ ഫെയിൽ ആവാറുള്ളൂ.
Good morning, everybody. We'll cover critical care management of GBS. GBS is an acute polyneuroradiculopathy. It is an autoimmune condition in nature, and the patients usually have a progressive muscle weakness and areflexia. So what usually happens is that they have this weakness that is ascending. Most commonly, that is what is seen. They will have weakness that is starting in the lower limbs, ascend up. Sometimes bladder and bowel is involved, and then can affect respiratory muscles. And usually the consciousness is preserved. So it's the most common cause of acute flaccid paralysis, with the global incidence about 1 to 2 per 100,000 person years. Incidence is about 1.5% higher in males than females. Usually affects any age between 50 to 70 years. Even pediatric population can also be affected. So what causes it is that precedently they will have usually a GI or respiratory tract infection, usually around 6 weeks before that. This is usually in 2/3 of the cases seen, and mostly these people will have a Campylobacter jejuni induced diarrhea. So that's what usually the preceding infection is. Also associated with CMV, hepatitis E, Mycoplasma pneumoniae, Epstein-Barr virus, and Zika viruses. So there have been these incidences where GBS outbreaks have been after Zika virus infections and herpes zoster outbreaks and all that. And also recently after COVID also, there are a lot of outbreaks after SARS-CoV also. Due to COVID, and sometimes because of the vaccine also, vaccine-induced GBS also. And also when the people have taken immunobiological GBS has been reported, and also seen in patients with lymphoma, also HIV and SLE. So this is the pathogenesis. What happens is molecular mimicry occurs. So patient has Campylobacter jejuni infection, immune response occurs, and when antibodies are produced, it cross-reacts with the myelin. So either it can cross-react with the nodes of Ranvier or with the Schwann cells. So what usually happens is, so what happens is the nerve looks like a punched out. So the nerve conduction is basically what is affected. It has got many anti-ganglioside antibodies. The levels can be checked, but usually we don't do it for diagnostic purposes. Then the basic mechanism is molecular mimicry, and the complement is activated. So this is what usually the course looks like. The patient has a preceding infection, and then after that, when the anti-ganglioside antibody level starts increasing, then the GBS occurs. So initially they will be okay with the start, and then once the antibody level starts increasing, so this around 2 weeks is the time gap. So slowly the weakness will start increasing. So usually the NAD is around 2 weeks time, and it kind of plateaus after 4 weeks. That is what usually the time course is. So that usually, so what the prognostication part is important. So they will say that the patient came walking, they came without any bowel bladder involvement. So usually they present along with the weakness. But what we have to anticipate is that in the next 1 week or 2, they are going to deteriorate. And after the deterioration only, they'll slowly start improving. So that's what from our side also we have to prognosticate them. So how do we diagnose it? It basically on clinical features. So it's progressive weakness of arms and legs, usually ascending weakness, and reflexes are absent, and 10% might have increased or normal reflexes, and the weakness doesn't go for more than 4 weeks. The features that support the diagnosis is symmetrical weaknesses, usually sensory symptoms usually is present, mild to symptoms are usually present. Cranial nerve involvement, usually along with the sensory motor involvement, they will have bifacial weakness will be there. Autonomic dysfunction is quite common. Respiratory insufficiency occurs when the weakness ascends up. When the respiratory muscles are involved, they will have ventilatory issues. Pain is a very common complaint in them, because demyelination happens, and they usually have very severe pain, especially in the back and the lower limbs, and they usually give a preceding history of infection. Other is electrodiagnostic testing. So there's different variants, AIDP, AMAN variants is there. And what is usually seen is what you see that is the CMAP. So nerve stimulation is given and the muscle action potential is recorded. So in AMAN variant, usually they progress quite rapidly. In day 1 you see, and day 8 you see that the potentials have significantly reduced. Then slowly that plateaus around 2 weeks. In AIDP, around day 30 is when maximum dip occurs, and by around 3 to 6 months, usually they recover. And another diagnostic modality is CSF analysis. What is important in CSF, it's basically done to rule out other causes like patients having meningitis or any sort of other demyelination, any autoimmune condition or something. To rule out that, CSF is done. Normally CSF is normal. The CSF cells is normal, so what you see is around 0 to 5 cells. So usually they will have less than 5 cells. What you see is the increase in albuminoprotein. So albuminocytological dissociation is the most common finding in GBS. And imaging is done, especially if respiratory involvement or bulbar involvement is there. We usually go and screen the brainstem and the spine. This is to see if there is any mechanical cause of the weakness, that is if any lumbar canal stenosis or any nerve root compression of anything of that sort is there, or if the patient has any brainstem strokes, because these are differential diagnosis. You have to rule out a stroke with a patient with bulbar palsy and respiratory insufficiency. But this is all to rule out the differentials, but mostly it is a clinical diagnosis. We went through this, and this is the mostly different diagnosis. I'm not going to go into detail. According to the different parts that is involved, going from the brain to the nerves to the muscles. So at every level, there are different differential diagnoses. How do we classify the different forms? There is AIDP, that is inflammatory demyelinating polyneuropathy. Then is AMAN, that is AMAN is motor involvement. AMSAN is motor and sensory axonal neuropathy. And then there is a pharyngeal cervical variant and Miller-Fisher syndrome. So this is how it looks like. This is the most common. That is the class. This one is the classic sensory motor. Then there is pure motor, pure sensory, paraparetic, and motor and sensory. And what happens in Miller-Fisher is that they have this ophthalmoplegia, ataxia, and areflexia. And Bickerstaff brainstem encephalitis, incidence is very less, but we do see patients with that. Whatever they kind of are in a logged in state. So there will be ophthalmoplegia, ataxia, areflexia, pyramidal tract signs will be there, and impaired consciousness. So this is also quite, it's even though the incidence is less, but we do see patients with this. So coming to the parts where it's very less likely that it is not GBS. So when the patient is having asymmetric weakness, when initially itself there is severe respiratory insufficiency, but limb weakness is not there. When there is hyperreflexia, preceding fever is there, bowel bladder is involved very early, and when the patient is having abdominal pain or vomiting, and consciousness is impaired. Other than Bickerstaff brainstem encephalitis, all other patients the consciousness is fully preserved. In the CSF have more cells, and usually all these patients blood test, everything will be normal. So anything of that sort is abnormal, you should consider other diagnosis. And usually when they peak the weakness within 24 hours, then usually there's some other cause, and relatively slow worsening, that the weakness is increasing after 4 weeks, then it is some other cause of weakness. So this is important, the disability, GBS disability score. 0 is a healthy patient, 1 is minor symptoms, but patient is having some sort of sensation is deficient, but motor power is they are able to run. In 2, they are able to walk 10 meters with more or less without assistance, but they are unable to run. 3 is able to walk but with help. 4 is a bedridden or chair-bound patient. 5 is requiring assisted ventilation at least for a part of the day. 6 is dead. So MRC that is Medical Research Council score is very important, because this is how you assess the power. So both sides where you assess is from the shoulder abduction, elbow flexion, wrist extension, hip flexion, knee extension, and foot dorsal. So you combine all these scores, like the power is good, against gravity patient is able to do it, against gravity and against resistance, and active movement but not against gravity, and there is visible contraction but not able to. Everybody knows the power scoring. So What is the respiratory Erasmus GBS respiratory insufficiency score? This is very important for us from critical care side. So this is what time did the patient come to hospital? Did they come less than 3 days? That is, the weakness has progressed so fast. So that means that there is very high chance that they will have respiratory insufficiency. Between 4 to 7 days, still high chance, but more than 7 days means that very less chance that they will get intubated. And whether facial or bulbar weakness is there, that is head and neck is affected or not, swallowing and coughing, whether it is affected or not. So if it is affected, that means that there is high chance that patient will have respiratory insufficiency. And all this, like all the group of muscles that I mentioned, what is the sum score? So if the score is very low, that means that there is high chance that they will get intubated. So it is basically the respiratory insufficiency score is basically to know whether they will get ventilated or not. So 0 to 2 indicates low need risk of mechanical intervention, 3 to 4 is intermediate risk, and more than 5 is high risk of mechanical intervention. So when do you admit these patients? So all GBS patients need not come to ICU. So if very mild weakness, they just need IVIG or plasmapheresis, they will not come to ICU. So when do we take them to ICU? When the patient is having breathlessness at rest or during talking, when you count the SBC, single breath count, if it's less than 15, any use of accessory muscles, when the heart rate or respiratory rate is increased, and when you check the spirometry, the vital capacity is less than 1 liter or less than 15 to 20 ml per kg. And when you do an ABG, there is any type 2 respiratory failure or they are having hypoxia. Those are the criteria that patient has to be shifted to ICU. Another thing is when they are having severe autonomic and cardiovascular dysfunction. That is, they are having arrhythmias or they are having postural hypotension. This autonomic instability is very common in GBS patients. Or when they are having severe swallowing dysfunction or cough is depressed and when the weakness is rapidly progressing. All these patients has to come to ICU. So patient coming to ICU, when will you intubate the patient? Because consciousness is not the criteria here to intubate because they all will have preserved consciousness. So when you will intubate them. So what is when the vital capacity becomes less than 20 ml per kg? Maximum, this is a 20, 30, 40 rule. That's what we follow. So when the vital capacity is less than 20 ml per kg, when the maximum inspiratory pressure is less than 30 and the maximum expiratory pressure is less than 40. So this is, sometimes we don't ask them to do incentive. A simple way of doing it is ask them to do a SBC. When the SBC becomes less than 8 is what usually when we'll electively intubate them. And when there is any bulbar involvement, that is when they have the inability to cough, swallow or protect the airway, that is they are not able to cough, secretions are pooling in the airway, to protect the airway we'll intubate them. And when they do an ABG has the evidence of respiratory failure or if they're having severe autonomic instability. Prolonged ventilation, tracheostomy will be considered and early respiratory physiotherapy is also considered. So how will you tube these patients? So when you're intubating, the very basic thing you have to remember is that they're very prone for autonomic dysfunction. So you will sedate them, you put the scope in, they will arrest. So that's very commonly seen. So the depth, you have to give the drugs very slowly, giving propofol, etomidate. Autonomic dysfunction is very, very common. You give even 5 cc of propofol, the BP will be like 60, 50 like that because autonomic instability is very common in them. And when you do laryngoscopy, a lot of patients arrest. So you have to be very, very watchful. You have to keep the crash cart ready. Be ready to give atropine or adrenaline because it is very common that patients can arrest while intubating. And before, it's usually an elective intubation, it's never a crash intubation because you're serially monitoring the patients, you're seeing them deteriorating. It's usually an elective intubation that is being done. So before that, adequately hydrate the patient and you give the drugs very slowly. You titrate the doses and give. So that is what you have to watch out during the intubation part in a GBS patient. Do we give NIV in GBS? Not really, because unless you are watching the patient minute to minute, NIV is a very difficult thing to do in GBS patients because it is a progressive disease. There's a very high chance that the airway reflexes might go, they will aspirate. So unless the patient, you're very sure that it's not going to progress, NIV we usually don't give them. Can they progress to respiratory failure very quickly and then increase the chance of your crash intubation. Emergency intubation and severe dysautonomia is very common if you put on NIV and then you're going to intubate these patients. So when do you do tracheostomy? So 2 weeks, you try to see how these patients are doing. You're able to wean them. Weakness is improving because consciousness is not your criteria. Whether the weakness is improving or not, you see muscle power, how it is doing. But if it is not, after 2 weeks, you will do tracheostomy. But even if after 2 weeks, but you're feeling that the patient is improving, you can still defer it for 1 more week. Like if the patient is like having an improvement in power, like they have not reached the nadir, but they are slowly improving, you can wait 1 more week, but usually not more than 3 weeks you'll wait for tracheostomy. So what are the risk factors for prolonged ventilation? That is their inability to perform a sustained head lift. So you ask them to lift their head up from the pillow, are they able to hold it for at least 5 seconds? So that's what we usually see. Able to lift the arm from the bed about 1 week after. So what you assess is after 1 week, after you intubate the patient, you assess the head, ask them to do a head lift, ability to lift the arm from the bed, and you do a electrophysiological study to see if any sort of improvement is there in the CMAPs in the electrophysiological study. And in centers which are adequate expertise, percutaneous tracheostomy is preferred over conventional tracheostomy. Other factors of general care, you have to prevent complications. So you have to regularly monitor the pulmonary function test, especially the SPC, the powers, every 2 to 4 hourly. If the patient is in stable phase, every 6 to 12 hours. You have to check for autonomic dysfunction. So patient has to be on continuous ECG monitoring, blood pressure monitoring, the pupils, and you have to also see that whether the bowel and bladder. Some patients might be normal, they will be self-voiding. So you have to see that when did they last void. Is the bladder getting involved? So involvement of bladder means that the weakness have ascended. So bowel and bladder is a very important aspect of monitoring for GPS. And also swallowing dysfunction. Are they choking? Are they able to swallow the food? If you are seeing any disability, any dysfunction in these, it means go straight away and put a Ryle's tube. And also they usually have pain. You give gabapentin or pregabalin for the pain. And psychological support, usually bed bound, fully conscious, so bound and in an ICU, isolated from family, very high chance that you'll go into depression. And because they are bed bound, very high chance of pulmonary embolism and also hospital acquired infections. And you have to prevent, especially with facial palsy, collar ulceration is prone, you have to prevent that, and decubitus ulcers and contracture are also very common. So physiotherapy and rehabilitation, active physiotherapy is also a very active part of early rehabilitation of these patients. So how do we treat them? You give them immunomodulatory therapy, plasmapheresis, IVIG, and biological drugs. So plasmapheresis is the first proven immunotherapy. It non-selectively removes the immunoglobulins, complements, and cytokines, because all these are in the pathogenesis of GBS. It should be initiated as early as possible. What we usually do is somewhere between 4 to 6. There are usually around 5 plasma exchanges be done. It's usually done on alternate days. So you wait for the serum levels of the complements to equalize. That's why you do it alternate days. Usually over 2 weeks we do the plasma exchange. And contraindication to plasma exchange is usually if the patient is having unstable hemodynamics, any coagulopathy or sepsis that is preventing you from putting the lines, and any hypocalcemia associated paresthesia, because plasma exchange and again will worsen the hypocalcemia and hypomagnesemia, and any problems with the vascular access. And treatment is also significantly reduced in the reduce the number of ventilator associated days in these patients. So when we do plasma exchange, you can extubate these patients early. Recommendations for plasma exchanges: start early as possible, and 4 to 5 exchanges over 1 to 2 weeks period. And it is also done early in patients who are deteriorating very fast, who are getting intubated very fast, who are having bulbar involvement. So anything that is showing a poor prognosis, you initiate the plasma exchange as soon as possible. It is not advisable to start plasma exchange in very mild patients like grade 1, that is a patient who is having sensory symptoms but can walk or run. In those patients, you generally do not initiate with plasma exchange. So and the patients who's mildly affected, that is in week 2 to 4, even still the mild symptoms only, they are not very progressing to higher grade of GBS, you don't need to initiate plasma exchange. IVIG neutralizes the autoantibodies or cytokines. It saturates the macrophage FC receptors. So the standard regime is per 0.4 gram per day dose. That's the total dose of IVIG is 2 gram per kg over 5 days. There are adverse effects of IVIG, infusion-related headaches, like if you give it very fast, and myalgia, chills, nausea, and aseptic meningitis. Severe complications can also occur, like myocardial infarction, congestive cardiac failure, TRALI, stroke. All the prothrombotic complications can happen, even renal failure and anaphylaxis. Steroids, we don't give steroids in GBS because already patient is demyelinated. You don't want to add on to something that is going to worsen their recovery. So because corticosteroids will inhibit the macrophage dependent repair process. So that is the reason why we don't give steroids in GBS. GBS in children, it is there. It is not very, it's quite rare. The only thing different of management, IVIG, plasma exchange, both can be given in children. The dose of where you give 2 gram over 5 days in adults, in children you give the 2 gram over 2 days. That's the only difference in management. In pregnancy, neither IVIG nor plasma exchange is contraindicated, but additional consideration, additional monitoring may be required when you give IVIG. So IVIG versus plasma exchange, there is not much difference in the terms of efficacy. But all the IVIG treatment are less frequently discontinued than plasma exchange, because usually when we do plasma exchange, you face difficulties with the vascular access, or the patient is having a lot of instability, autonomic instability with doing the exchange. That is one of the most reasons why we discontinue plasma exchange. IVIG is better tolerated by everybody. So that is why IVIG is discontinuation of plasma exchange is one of the reasons. And you have to give a higher dose of IVIG. There is no evidence of that. The standard dose is fine. And do we give a second dose of IVIG? Usually do not. Or do we give like combination, like do we do plasma exchange or immediately followed by IVIG? That is not usually done. So what you do is, for a patient, you first give IVIG or plasma exchange, and then you wait for the results. You wait for usually 2 weeks. That's what usually done is. Either one of the modalities you give, wait for 2 weeks to see what effect is there, and then maybe give the other modality. First you give IVIG, watch and wait for the results. If patient is not improving and still worsening, you can consider giving a plasma exchange. That's what is usually done. Together, we don't give it. What do you monitor in the ICU? You have to monitor for autonomic dysfunction, that is ECG monitoring and heart rate, blood pressure, and bowel and bladder function. You have to do respiratory monitoring, that is a single breath count, vital capacity. You have to monitor the ABGs and the 20-30-40 rule. The muscle strength is quite important to monitor, and also the swallowing and coughing. How do you monitor for, how do you manage the progression? If some patients, they have, like with the standard plasma exchange, they do not improve in the first 4 weeks, you can consider repeating the regimen or going over to the other regimen. There is something called TRF, that is treatment related fluctuations, which is in very small group of patients. So that is 100 patients you treat, around 5 to 10 patients you will have this treatment related fluctuations. That is, they will improve, again they will deteriorate. So then you have to treat them again. So they can benefit from an IVIG or plasma exchange as a repeat course of treatment. So when these patients have 3 or more treatment related fluctuations, you label them as CIDP. Or if the clinical deterioration is progressing more than 8, usually 2 to 4 weeks, they will reach an nadir and then start improving. But if the worsening is going more than 8 weeks, you label them as CIDP. So the complications, how do you manage them? Choking, cardiac arrhythmias. Sometimes patients can have bad arrhythmias, or bradycardia is very common. You have seen some patients whom you just give turns, they'll arrest. So very severe bradycardia patients, if all your conservative measures is like usually glycopyrrolate is given, so all that is not working, even pacemakers has to be inserted in some patients because the bradycardia is so bad. Very prone, they are in the hospital for a long time, so hospital acquired infections. And delirium, depression, and tactile and allodynia, all this happens because very limited communication happens. Then urinary retention, constipation, corneal ulcerations, all these can occur. Then pressure ulcers, and hyponatremia is seen in almost all the patients. And they are bedbound for a long time, not moving, they develop contracture. So early mobilization, early rehabilitation all becomes, that is multidisciplinary care becomes very important in these patients. Occupational therapists, the physiotherapists, they all have to come in and start working with the patient as early as possible. Dysautonomia occur in 65% of the patients. It's mostly seen in the acute phase of the disease and usually improve by around 3 months. And cardiovascular, what you see is sinus tachycardia, hypertension, hypotension, labile blood pressures, non-specific ECG changes, and bradycardia, asystole, and sudden cardiac arrest is also seen. So why it happens exactly we don't know, but probably it is affecting the demyelination is also affecting the sympathetic ganglia as well as the vagal centers in the brainstem. Sometimes when you suction the patients itself, they will have all these issues. So you have to be prepared for that. Postural hypotension if the patient is having, hydrate the patient, low dose phenylephrine or fluorocortisone can be given. Only even antihypertensive, because they're very prone for hypotension, shock tackling ones only has to be given. Gastrointestinal constipation and gastric immobility is there. You have to say if something like that happens, ileus, then cessation of enteral feeding and gastric decompression, pro-motility drugs, and you have to reduce the opioids that you're using in these patients. Urinary dysfunction is seen in around 25% and complete urinary retention in about 9%. Thromboembolism, DVT and pulmonary embolism are early complications because of the immobility. You have to monitor for any leg edema, chest pain, shortness of breath, or hemodynamic instability. Usually these patients early itself receive pharmacological prophylaxis. Heparin or Clexane is usually given for them. Pain is a very common thing in GBS, and usually give them some sort of anxiolytic along with the pain, usually gabapentin or pregabalin, because it's a neuropathic pain they're having. Malnutrition, it is in a hypermetabolic state, so it's a high energy requirement, so you have to give high protein and high calorie nutrition for this, and close monitoring of the hydration, weight, and protein and nitrogen balance has to be done. So how do you predict the outcome? So if the patient is old, the high chance of poor outcome. If they have had a diarrhea prior to presenting, high chance of poor outcome. And the disability score, that is the amount, whether they were bed bound or whether they ventilated, all this leads to the poor outcome. So mortality is around previously it used to be very high, now the mortality is less than 10%. There is 2 to 5% chance of recurrence, but that is very less. So how do you rehabilitate them? You have to have psychological distress management, physiotherapy, pain management, and the fatigue management. So this is usually when the summary of whatever I have said, when do you admit to ICU, when do you start treatment, and what are the options of treatment, what do you monitor in these patients, and the complications you are anticipating, how do you handle those complications, and how the disease is progressed. And another thing is, how do you plan the long-term care, that is how do you predict the outcome and how the rehabilitation is done. Other things, complement inhibitors like eculizumab and IgG degradation products and biomarkers can be used in GBS. This is just the summary. Thank you.
A few declarations to make. I have 2 topics today. This is a slightly more complicated topic than my second one, which is PICS. So I'm going to take slightly more than 30 minutes for this and slightly less than 30 minutes for the second. So the cumulative total dose of me will not exceed the maximum limit which is allotted. Kiran, with your permission, because your time is going to be a little. All right. And I learned this from the best, Dr. Rajagopal, and okay, I'll be able to see this. Yeah. So I have not only learned it from him, I have stolen his slides. Is there anyone from Chennai here? Okay. Please don't tell him. Okay. It's a little difficult, Jacob, I think. Huh? Yeah, I think I'll be audible even without the mic there in behind. Yeah, all right. So all the organs in our body talk to each other, right? And we have all heard the joke about all the organs saying who is the best, and finally the rectum went on a strike, right? I mean, is there anybody who has not heard it? I mean, we all heard it. So thing is, we all know each organ talks to every other organ. But how is this interaction between the heart and lung different from that? How do these organs talk to each other? So you have neural network, you have feedback loops, you have chemicals, endocrine, paracrine, then you have your immune system, which will like modulators of inflammation, modulators of stress, injury. So these are all basically neural or chemical interactions. But that is not what we are talking about here. So when we are talking about heart and lung interaction, we are talking about physical interactions because of limitation of space. So anybody who has shared a room and a toilet with somebody else knows that difficulty, because only one person can be in that limited space for one particular time, and there has to be a give and take, right? So when we talk about heart lung interactions, we are talking about the changes that the functions of each will make on the function of other, but particularly we will be stressing on what the tidal inflation, either spontaneous or mechanically initiated, will have the effect that it will have on the hemodynamics, because that's what's very important for us. All right, so all this is because they share a room. Okay, so there is a thoracic cavity, the lung and the heart is inside. You could almost say that the heart is covered by the lung, not entirely, but almost. All right, so the pressures of each of these chambers are going to determine how, because there are fluids which are going in, air going in and out of the lung and blood going in and out of the heart. Air which is compressible, blood which is not compressible. Okay, so a lot of physics is coming in. So when we breathe, whether it is spontaneous or whether it is a positive pressure breath, the pressures that we generate in the airway gets transmitted somehow to the vasculature. That is no surprise. We all know how that happens. Okay, so which type of airway pressure will be the determinant of this? You have plateau pressure, you have peak pressure, you have the PEEP. Okay, so to make you understand that, I will ask you, which arterial pressure is taken as the determinant of perfusion? Is it systolic pressure, diastolic pressure, mean? Okay, the mean arterial pressure is not the pressure which is there at all the time, but it is an integral of the total pressure which is there in one heartbeat. Likewise, we have the mean airway pressure, which is an integral of, it will depend on how much is the peak pressure during inspiration, it will depend on how much is the plateau, and it will also depend on how much is the PEEP and also the ratio between I and D. So it is depending on how much is the pressure which is felt at the alveolus, and that is determined by the mean airway pressure. How do you get the mean airway pressure? If you are on the ventilator, you can directly read it off. You get a mean airway pressure there. Okay, so it is a mean airway pressure which is the determinant. So you can change it by increasing the peak pressure. You can change it by, increase it by increasing the PEEP. You can also by changing the I ratio, increase the mean airway pressure. These are all the maneuvers that you will do in an attempt to increase your oxygenation, if you remember. All right, so the mean airway pressure is important. So the magnitude of the change that is produced on the vasculature will depend on the magnitude of the tidal volume as well as pressure. So two things, the pressure as well as the volume. Of the pressure, we are talking about the mean airway pressure. It will also depend on the compliance of the lung and the chest wall. Okay, so if it is a very compliant lung, the airway pressures are transmitted very well. If it is a stiff ARDS lung, the airway pressures are not transmitted that well. That is why if you have an ARDS and if you keep a high PEEP, even if there is a raised ICP, it is not getting transmitted that well. You know that concept. Okay, so it will, how much that mean airway pressure will have an effect on the vasculature will depend on how stiff the lung is and how stiff the chest is. The stiffer the chest, the more will be the effect of the pressure. It will also depend on the location of the vasculature. Let me explain that in the next. So, for structures which are there intrathoracically as well as outside, for example, the IVC, the SVC, or the aorta. Okay, so for them, the major change will be the change in pressure in the thorax. Okay, so during inspiration, you can see, because there is a negative pressure which is created by the movement of diaphragm down, and the venous backflow to the right atrium increases. Whereas if there is a positive pressure, there is a pressure within the intrathoracic cavity, the RA is compressed and the venous return is reduced. Okay. Whereas we have the pulmonary vasculature which is not extending outside the thorax. Okay, so the driving pressure for them does not change, because for the other structures there is a gradient between the pressure inside the thorax and outside the thorax, but for them they are completely within the thorax. So what affects them more is not the change in pressure but the change in the alveolar volume. Okay, if the alveoli are stretched more, some of those vessels can be compressed. If they are stretched less, they can be not compressed. All right, so it depends on the position of these vessels, whether they are intraalveolar or extraalveolar. So what creates a flow in a blood vessel? There has to be a pressure gradient, right? Okay, so we all know about the pressure gradient for the arterial system. What about the venous system? Has somebody talked about the Guytonian curves? You know that because you are going for exams, you should be knowing the Guytonian curves. The concept of mean systemic filling pressure. What is the mean systemic filling pressure? It is the driving pressure for the venous filling. All right. So in the if in the resting stage, if you take, there is a resistance to the flow by the right atrial pressure. What drives the blood into the right atrium will be the pressure in the systemic veins, which is the mean systemic filling pressure. Okay, so if the mean systemic filling pressure is more than the CVP, the blood will flow. The function of the right heart is to keep the CVP less than the MSFP. So if it is less than the MSFP, the the venous blood flow will continue, and the MSFP is determined by the volume of the blood as well as the state of constriction of the blood vessels. So how much of the venous plexus is recruited. All right, so that is an important concept. So the other concept is that the pressure gradient we are talking about is also the transmural pressure, because not just the intraluminal pressure. Just to illustrate that point, two situations. The first situation, you have the aorta and the left ventricle. So if the intrathoracic pressure in inspiration because of negative thoracic pressure is -20 and the aortic pressure is 80, the LV needs to generate 80 minus -20, that is 100 millimeters of mercury to actually pump into the aorta. Okay, whereas if the pressure inside the intrathoracic cavity is +20 in expiration, for instance, or because of PEEP or whatever, then the pressure that it needs to generate is 80 minus +20, which is 60. So what has happened? The afterload of the LV is reduced. So when you have a negative pressure, because of the negative intrathoracic pressure which is created, the transmural pressure is changed, and because of that, a negative pressure will increase the afterload of the LV, and a positive pressure will decrease the afterload of the LV. Is that concept clear? All right. So now with that understanding, we will go to what happens at the RV preload, RV afterload, LV preload, LV afterload. All right, starting with the RV filling and venous return. So in spontaneous breathing, we have already said what happens when you're spontaneously breathing, because your diaphragm is contracting, you're creating actively a negative pressure within the thorax. So the negative pressure will actually increase the venous return. All right, so the RV preload increases. That's clear. All right. Okay, I didn't talk about the positive pressure. All right. So if it is a positive pressure breath because of positive intrathoracic pressure and the compression of the RA and RV, the venous filling can be reduced. All right. Okay. So what is this point? The right atrial pressure where there is no venous filling is or there is no gradient to drive the flow. So that pressure is the mean systemic filling pressure. Okay. So the vascular filling as the right atrial pressure comes down, the venous filling will increase. All right. So for each right atrial pressure, there is a fixed amount of venous return, and when you give a positive pressure, what will happen is because of the positive pressure transmitted to the right atrium, the right atrial pressure will increase and the venous return decreases. So if you want to actually maintain the venous return, what could be done? You need to make sure that the system is filled. Okay, you give some fluid, and how will that fluid increase from this blue line? How did it go there? Yeah, because there is more volume. A part of it will be in the stressed venous volume, and now a little bit of increase in right atrial pressure has also happened, but now we have moved the curve to a different point and you will have a better venous return. So the effect of positive pressure on the venous return on the right side is a negative influence, and how much negative it will be determined by the filling state of your venous system. If you are well filled, it will have less effect. If you are dehydrated, it will have a bigger effect. You see that every day. Somebody who is dehydrated, whose volume status is poor, if you give a high positive pressure, you will see that that produces hypotension. Okay, and this is the mechanism. One thing that we need to understand is that even though we say this is the primary effect, there is also a secondary effect, because the increase in positive pressure which is transmitted to the thorax also sometimes produces a increased pressure in the abdomen, and because of that, in a patient who is comparatively fluid filled, the effect on the preload is not very dominant, which is why in most of the patients, if you put them on an IV or positive pressure which is not very high, you don't get a hypotension. Okay. So because of the pressure on the diaphragm, the intra-abdominal pressure increases, and the driving pressure now between the pressure in the abdominal IVC and the RA is now driving the venous return. Okay, so in a fluid filled patient, the effect on the preload is less. That is what we said earlier. Coming to the RV afterload, it's a little complicated because the RV, which actually RV, how does it pumps into the pulmonary vasculature, and the pulmonary system, you have two types of blood vessels. You have the intra-alveolar as well as the extra-alveolar vessels. The extra-alveolar vessels are sort of spiral, and the alveolar vessels can be compressed by the alveolar stretch, whereas the extra-alveolar vessels are not so compressed when you have your tidal inflation. So, and how the resistance of each of these vessels change with tidal inflation is depicted on what is called the classical Wittenberg curve. So, for the extra-alveolar vessels, when you have stretch, the vascular resistance increases, whereas for the no, I'm sorry, the extravascular, the resistance actually come down, whereas the alveolar vessels get stretched by inflation, the tidal inflation, as the alveoli are inflated by inspiration. And the total pulmonary resistance is a function of both together, and the least point or the best pulmonary vascular resistance is at this point of lung volume, which will correspond to FRC. Okay, so that the ideal point where your lung should function, the pulmonary vascular resistance is less. At either sides of the pulmonary the FRC, your total pulmonary resistance will increase. Okay, so alveolar collapse is not good, distension is not good. Both will create increased load to the RV. Okay, so what are the clinical implications of that? One is that the concept of the baby lung and the low tidal volume inflation is good, because over distension actually will produce RV distension, RV failure, and iatrogenic RV failure is one of the things which is usually undetected if you do not do serial echoes and look for it in patients with ARDS. Okay, so one of the possible ways in which there are multiple reasons why low tidal volumes is useful. One of the reasons why it is increasing the safety of mechanical ventilation is because it reduces the degree of RV failure which you are iatrogenically producing. Right. The other important implication is the selection of PEEP. Okay, so when you give PEEP, if it produces an improvement in oxygenation, how does it produce an improvement in oxygenation? It recruits previously unrecruited alveoli. So if more alveoli are recruited, the PVR will come down, because those vessels, the pulmonary ischemic hypoxic vasoconstriction will prevent the vessels there from dilating when they are not perfused, when they are not ventilated. When those get ventilated, those vessels also will get recruited and the pulmonary vascular resistance will come out. So PEEP can be good if it increases oxygen, but at the same time, if it produces over distension, again it can produce the same mechanism, RV failure. Okay, so in an unselected patient, it can be deleterious. So how you titrate PEEP has to be based on serial monitoring of the RV function using echocardiography. The other thing we always think about PEEP producing, getting the hypoxia better and also the PVR. One other reason why it would increase the PVR is because of hypercarbia and not because of alveolar distension or changes directly on the alveoli. Because when you have to increase the PEEP, if you are using lung protective ventilation, you have to give way somewhere, because your plateau pressure cannot be exceeded. So if you are increasing PEEP, unless it produces a improvement in the driving pressure, your total pressure is going to come down and your tidal volume is going to come down, isn't it? Normally. So if the increased PEEP results in recruitment and your driving pressure comes down, the total tidal volume will not come down. But that happens only in a small percentage of patients where you are really happy doing that. But in many of the cases, it does not happen. So in that situation, if the tidal volume comes down, the cost is hypercarbia. And hypercarbia increases vasoconstriction, pulmonary vasoconstriction. And one of the strongest predictors of RV failure in ARDS ventilation is hypercarbia. That is something that you need to remember. So most of the time we say don't worry about the carbon dioxide, because the carbon dioxide don't kill anyone. So we have permissive hypercapnia and things like that. But be aware that hypercarbia is not very good for the RV. So whenever you are doing permissive hypercarbia, you need to be aware of this effect. We are finished with the RV now. We are going to the LV. So the LV filling is directly affected by how much is pumped by the RV. Okay, so unless it goes out of the RV, it cannot come into the LV. All right. So these are connected in series. So the RV filling during inspiration increases, during expiration it decreases. So then, because it's a low pressure system, it goes into the pulmonary system, and then all that blood has to come back to the LV, right? Cannot stay there unless it's going to produce pulmonary edema. So there is a lag between the RV and LV, what happens to the preload, because it takes some time for the pulmonary transit time. So it happens in series. So if you look at the stroke volume or the pulse pressure, you will see that you will have an increase in your RV filling, actually a decrease in the RV filling initially during inspiration. Okay, let's again take during inspiration. If it is a positive pressure breath, okay, I got confused between, I'm now talking about positive pressure breath because that's the time when we are talking about your variability, pulse pressure variability and stroke volume variability. So if it is a positive pressure breath, the direct effect which happens on the right side, on the left side, is a squeeze of the pulmonary vasculature and a small initial temporary increase in the left side filling, because the pulmonary vessels, because lung is inflated, vessels are squeezed and the venous system, it comes into the left side. Okay, so initially temporarily the left side preload increases and the stroke volume will increase, and the effect on the right side by positive pressure is a reduction in the RV filling, and that reduction in the RV filling and the reduction in the stroke volume gets reflected on the left side after pulmonary transit in a few beats, 2 to 3 beats. So what will happen when there is a positive pressure ventilation on the left side is initially there is a small increase followed by a big decrease. Okay, so the difference between that will depend on the contractility of the heart, where in which position of the Frank-Starling curve it is. So if the heart is here, a small change in the preload will produce a big change in the stroke volume. If it is here, it will not produce that much. All right, so here if I decrease the preload from here to here, the stroke volume from this point will come down to this point. Okay, so the delta down, or the PPV which is coming down, or the stroke volume which is coming down, will be big if the patient is in the steep portion of the Frank-Starling curve, whereas, so this will be the fluctuation, whereas if we are on the plateau portion of the Frank-Starling curve, we have produced a preload reduction from this point to this point, but the stroke volume reduction is only this much. Okay, so the change in PPV or SPV is less. Okay, so this is why we use the pulse pressure variation or the stroke volume variation to see which portion of the Frank-Starling curve the patient is at present in. Okay, so when you do positive pressure ventilation and that positive pressure reducing your RV filling, which gets reflected in the LV filling, that is basically what we are looking at. The delta down is what is telling you you have a small delta up and a big delta down. The big delta down is what is determined by the preload of the LV. Okay, that is why that is called a dynamic parameter. So the preload of the LV is changed from this point. You have a stroke volume at this point, or the a surrogate of stroke volume. It could be the pulse pressure or the stroke volume, and you change the preload from this point to this point and see what has happened to the stroke volume. So that is a dynamic index. You are actually changing the preload and seeing what happens to the cardiac output or the stroke volume. So that is the reason why these indexes are called dynamic indices, unlike the right atrial or pulmonary artery occlusion pressure or things like that. And that is the reason why PPV and SBV are good predictors of volume responsiveness. Okay, coming to the LV afterload. Okay, we spoke about the transmural pressures, and which is something which we have to remember. So I don't have to repeat that again, right? So all right. Okay, so when you have positive pressure, what happens to the afterload of the LV? The afterload of the LV is actually less. Okay, so the LV is actually helped by a increase in the positive. Okay, so I used to wonder the transmural pressure that we are talking of is also affecting the aorta, and why does it not create a problem? Because the aorta is opening into the abdominal aorta, because the pressure, it gets some conduit to relieve of that pressure, positive pressure, which is there in the intrathoracic area. So basically the increase in pressure is affecting only the something has happened to the Is it visible now? Can I move on? All right. Okay, so when you have a positive pressure, the LV afterload is reduced and you have a better emptying. All right, so that better emptying actually produces a increase in the stroke volume. I think we spoke about that. And the clinical implication is this. This is why a positive pressure ventilation is the primary method of treating pulmonary edema. So when you give a patient a CPAP, an IV, or and give a bit of positive pressure, it actually improves. So many people think that it is because the pressure is taking away all the fluid from inside the alveoli outside. It is not that. So what happens is, when you give a positive pressure, the afterload of the LV is better, so the LV can actually empty better, which will also actually improve the diastolic function of the LV, because it can fill better. If it can empty better, it can fill better. So it actually improves your LV functioning, and it is one of the most important ways by which we treat pulmonary edema now. The other clinical implication is what is commonly called the weaning induced LV failure. So before weaning, you think that they're doing fine, and when you start weaning, or they look comfortable even on a CPAP of 5 or 6, and you extubate, and then they find that the patient has gone into pulmonary edema. What has happened is that negative pressure again increases the afterload of the LV, and a heart which was compromised, which was undetected because of that minimal CPAP that you had going on, and now that becomes revealed because that is no longer there. So this is something which you have to look at when you have a weaning failure, and again the treatment can be extubation to NIV. Coming to the last part, we have looked at RV preload, afterload, LV preload, afterload. The last part of the heart-lung interaction is about the ventricular interdependence. So I told you they are sharing a room and also a bathroom, because the RV and LV, which are connected in series with the lung, also share a septum. All right, so this is normal, but there is the total capacity of the pericardium cannot be exceeding a limit. So if it is limited, then each chamber can fill at the expense of the other. In normal situation, it does not happen, but if it is limited, for example, if you have RV failure, or if you have pericardial effusion or constrictive pericarditis, or whatever reason, when it is limited, each chamber can fill at the expense of other only. Okay, So if there is pulmonary artery hypertension or pericardial tamponade, these are the most common clinical situations that we see. So in contrast to what we saw earlier, when your inspiration and expiration producing changes in the pulse pressure or the stroke volume, because they are connected in series, there is a delay between what happens in the RV getting reflected on the LV. It takes a few heartbeats for that pulmonary transit time, whereas this is in parallel, because what happens to the RV immediately, because the RV push the septum onto the other side, immediately the same beat, the LV is going to be affected. So there is no transit time between there, and that is an important distinction that we need to make, and I'll tell you why soon. All right. So this is one of the major limitation of the dynamic parameters that we spoke about earlier. Let us say if there is an RV failure, the septum is like this. Okay, let us see if because of this reason, because you during inspiration, because there is an RV failure, the RV will fill because there is negative pressure there, and because of that the LV filling will be compromised. Okay, so you will have a pulse pressure variability, but that does not mean that the patient is volume depleted. Okay, so if you look at the SVV or PPV, there will be variability, and without looking at an echo thinking that it is not, it's because the patient is fluid depleted and you give fluid, nothing happens to that PPV or SVV. It is because that variability was because of the RV failure and the limitation of one ventricle filling has on the other ventricle. Okay, is that clear? I see a little bit of blankness. So when there is a RV failure, let's say there is significant pulmonary artery hypertension, core pulmonary, the afterload of the RV is also high and the septum is pushed towards the LV. Okay, the total volume which can be accommodated is less. Patient takes a breath. Okay, negative pressure. They are usually dyspneic, right? Big negative pressure. RV fills. The LV cannot fill that much because the total volume that can be filled is less. Okay, so that RV is now emptying reasonably better than what it was before. It is not still normal, it is better than before because there is pulmonary artery hypertension, and because the preload is better, it will eject better, but the LV is now ejecting less. Okay, during expiration the reverse happens. There is a positive pressure, the RV is actually sort of compressed, so the LV is no longer compressed and the LV can fill and the LV stroke volume is up. Okay, so that will look as if there is a respiratory fluctuation, right? And if you look at the PPV or SVV, it will be high. Okay, if it is due to a failure, then giving fluid is not going to actually improve the patient, it will only worsen the patient's situation. Okay, so that is an important caveat that you need to remember. Two more things and then I will stop. Pericardial tamponade, the pulsus paradoxus that you, what is the explanation? It is again because of the interventricular dependence. Okay, so so because the pericardium, the tamponade is pressing on both the right side as well as the left side, because the compliance or the right side vessel walls are less thicker, the effect on the diastole is more on the right side, so it is sort of compressed and the left will get filled at the expense of the right, and then the patient becomes dyspneic because that is a compensatory mechanism and takes a big negative breath, at which time, because of the reduction of the positive pressure, the RV will fill and the LV cannot fill, and so there is a big difference between inspiration and expiration like this, and that produces pulsus paradoxus. So what is important is that, so during inspiration the stroke volume of the RV will go up because of negative pressure, it has more filling, and the LV, because the septum has been pushed up, it will come down. Okay, and expiration, the reverse will happen. Okay, so it is happening at the same time, so in parallel, but the direction is opposite. So some of the phrases that is used in literature, it says in parallel and out of phase. So don't get confused. The out of phase is not in relation to time, it is in relation to the direction. Okay, so sometimes when you read initially, it can become a little confusing. So it happens at the same time, that is why it is called in parallel, but the direction of change is in opposite directions. All right. So if you look at the RVOT and LVOT stroke volumes, so it will be completely in different directions. Acute severe asthma. Again, you get pulsus paradoxus. Why? The mechanism is again important. What is different in acute severe asthma is the significant dynamic hyperinflation. The lung is operating at a point far above the FRC, okay, and the RV afterload is high, and during inspiration there is, because of the big negative pressure breath that the patient takes to take in, the drop in the intrathoracic pressure can be quite big. Okay, so this big negative pressure actually produces a big increase in the RV afterload. Again, remember the transmural pressure. Okay, so because of that, what happens is a decrease in the RV systolic, RV stroke volume, and a dilated RV, because the RV cannot completely empty because of the raised afterload, and RV is dilated, the septum pushes the LV, and because of that the LV cannot fill. Okay, so what happens in acute severe asthma is also a pulsus paradoxus, but in contrast to what happens in an acute pericardial tamponade, it is in phase. Okay, so in inspiration both RV and LV stroke volumes come down, and in expiration both RV and LV stroke volumes go up. So it is in parallel and also in phase. Okay, do I have time for questions?
Yes.
All right. Anyway,
Are you going to ask them questions?
do you want me to?
Any questions, please?
In RV failure, generally you will get a exaggerated change in the inspiratory expiratory pulses, but you do not get pulsus paradoxus. So the pulsus paradoxus you get only in pericardial tamponade or acute severe asthma. Echo. If you look at only the pulse pressure variability, you will not detect. Yes, but how are you going to measure it?
Output will be down in the immediate next waveform.
Yes. Yes. Okay. So clinically, you can see whether it is in series or in parallel. That is one way of looking at it. But it is not in a patient who is tachypneic and tachycardic. That is the situation most of the time. Practically, it is not that possible. You can detect it by looking at the phase difference. It is well and good. But in practice, to differentiate it, you need an echo. We need a suspicion that the patient is going in for RV failure. All your clinical signs of RV failure are going to be there. You might have raised JVP, you might have edema. So if you would look at those clinical indicators, they will tell you to look for RV failure, and then you do an echo. So if you have, like Jacob said, if you have the generally, how do you get PPV or SVV? You have a hemodynamic monitor. You cannot directly look at it in arterial line and say the variability. Okay, so that actually gives out a value, but to actually see if it is in phase, you need to have a curve of that along with the curve of the inspiration and expiration, possibly an ETCO2 with the same speed. Okay, that is a situation. I mean, if you are looking for that, you need to adjust. Most of the time, the default speed of ETCO2 is not the same as the speed of the pressure tracing. So if that will be at 25, you need to set the ETCO2 speed at 25, and then you can look at the whether it is in phase or not. But I mean, without doing that, if you just look at the monitor, you're going to miss it. Okay.
Okay, good morning. Jojo sir എടുത്തു കഴിഞ്ഞ ഉടനെ എടുക്കുന്നത് കുറച്ച് ബുദ്ധിമുട്ടാണ്. So, fluid resuscitation, concepts and controversies. There are lot of controversies. എല്ലാം 30 minutes പറയാൻ പറ്റത്തില്ല. പറ്റുന്ന controversy പറയാം. And concepts. So, you know the indications for fluid. What are the main indications for fluid in ICU? Categories. One is resuscitation, maintenance, replacement, and nutrition. Resuscitation, you know, you give resuscitation fluids to correct the intravascular volume deficit. Replacement, when patient cannot take the replacement fluids orally, we will supplement with IV fluids. Maintenance, like when patient is on NPO, we use maintenance IV fluids. And for nutrition, we use dextrose as a part of parenteral nutrition. So, coming to the old physiology, body fluid composition, see about 60% of the body weight is composed of fluids in males, and females somewhere around 55%. And out of the 60%, 2/3 is intracellular and 1/3 is extracellular. Extracellular means intravascular and interstitium. So, out of this 1/3 extracellular fluid, 20% of this 1/3 is plasma. So, when we are giving fluids, we want our fluid to remain here, right? We don't want our fluid to be anywhere other than here. Okay. So, will the fluid remain there? That is the question we need to ask. So, there is a layer known as glycocalyx. So, glycocalyx is it is composed of this peptidoglycans, glycosaminoglycans. So, it is the thing which maintains the integrity of the capillary wall. Okay. So, you know about Starling's equation. So, what is this reverse Starling's equation? What is the difference between Starling's and reverse Starling's? Vascular pressure doesn't matter. Is it vascular pressure and interstitial pressure? I mean, you are saying that in reverse Starling's there is no vascular pressure, but interstitial pressure is there. Is it? No. Yeah, because earlier it was the Starling's forces or Starling's equation. Okay, these forces determine the net movement of water from intravascular to extravascular, or extravascular to, or that is from interstitium to intravascular. So earlier it was, so this is the net movement of water. These are constants. These are capillary hydrostatic pressure. interstitial hydrostatic pressure. And then there is the capillary oncotic pressure. Okay, your albumin contributes to oncotic pressure. In the stalling, it was interstitial oncotic pressure here. Okay, so in the Starling's equation, it was capillary hydrostatic pressure, interstitial hydrostatic pressure, capillary oncotic pressure, and interstitial oncotic pressure. Is there any protein or albumin in the interstitium? No. So obviously the interstitial pressure was 0. Okay. Later only they found that there is something known as glycocalyx, and it is this thing which contributes or which determines the transfer of fluids, because there is albumin in the glycocalyx. Albumin is attached to glycocalyx. So in the reverse Starling, they replace the interstitial hydrostatic pressure with the glycocalyxal hydrostatic pressure. So when the plasma hydrostatic pressure increases, like in, when will the plasma hydrostatic pressure increase? Hypervolemia, fluid overload. So what will happen? Fluid will move from high pressure to low pressure area. So now when the plasma oncotic, hydrostatic pressure increases, fluid will move from the vascular area to the interstitium, and vice versa. What about oncotic pressure? What happens when plasma oncotic pressure decreases? It will be the reverse. Okay, that is when plasma oncotic pressure decreases, like in hypoalbuminemia, fluid will move into the interstitium. So whenever plasma hydrostatic pressure increase, fluid will move from the vasculature to the interstitium. When plasma oncotic pressure decrease, then also fluid will move from the vasculature to the interstitium. That is how your pulmonary demand fluid overload happens. Okay. So just a glimpse through crystalloids. I hope all of you know regarding the composition of individual fluids, because during the Viva station you may get a fluid and you will have to mention the composition. Now, colloids. This was a previous question. Evidence for albumin in ICU. So, what are the indications for currently the approved indications for albumin in ICU? Yes, large volume paracentesis. Then hepatorenal syndrome. Yes. Then yes, SBP. Yes. Then any resuscitation? Massive fluid resuscitation in hypovolemia. That is, yes. Based on which trial? Which trial recommends, or which trial suggests some benefit with albumin in septic shock resuscitation? Which trial? Albios? We will see. Okay, fine. So basically, when there is a need for large volume resuscitation in septic shock, okay, you need large amount of crystalloids. So in such case, as a volume sparer, you can use albumin. Remaining SBP, HRS mainly due to liver. And then another indication, yeah, plasma exchange. Okay. So what is the crystalloid colloid ratio? One crystalloid is equal to how many? I can hear different numbers. 1 is to 1.4. Any other? Paka? One. Based on which trial? Safe trial. Septic shock, use of albumin in septic shock, which trial? Safe trial. Again, safe trial. And in safe trial, which concentration of albumin did they use? So, what was the negative thing they found in subgroup analysis? Reason? Most probably because of the 4%. So, regarding the trials of albumin in ICU, 3 trials. ES trial, again that was a multi-center trial. Septic shock patients, 20% albumin with saline. 28-day and 90-day mortality, no difference. Then SAFE and Albios trial. SAFE trial compared 4% albumin and normal saline, 28-day mortality, no mortality benefit. But in the subgroup analysis, they found that there was some benefit in septic shock patients who received albumin, and there was an increased mortality when albumin was used in traumatic brain injury. So earlier there was a concept that 1 crystalloid is equal to 3 colloid, 1 colloid is equal to 3 crystalloid, but this SAFE trial showed that there is not that much difference, it is only 1:1.4. Okay. And Albios trial, what did they do in Albios trial? In Albios trial, they gave albumin so that the serum albumin level is above 3. That was their goal of albumin resuscitation. They tried to keep the albumin above 3. But what did they find? No significant mortality benefit. Okay. Can we use albumin in burns? When? 1 hour, 2 hour, 24 hours? Time. Okay, large volume. Definitely burns will need large volume resuscitation. So when a burns patient come, using which formula use for burns? What is the difference? Parkland it was 4 ml per kg and now modified it is 2 ml per kg. So definitely that will also come to a larger quantity. So you will use albumin straight away? Then when? Okay. Yeah, maybe that time period. I think earlier it was 24 hours, but now I think it was somewhere around the latest ABSA mentioned that after 8 hours maybe you can use if needed. Not mandatory that you should use. Now coming to the trials comparing crystalloids and colloids. What are the trials? Yes. Just no, crystalloids and colloids. Not split. Just Scandinavian 6S trial, crystal, Christmas. So what did just compare? HES with saline. So what did they find? Yeah, increased renal and no mortality but increased renal side effects and more requirement of blood transfusion. Scandinavian 6S compared HES with the RL. Again mortality was high, more requirement of RRT. There was no difference in the bleeding incidence or transfusion requirements. Coming to the crystal and Christmas, again no benefit for colloids in crystal and Christmas also, only finding was the mortality, there was no difference, but the amount of fluid required for hemodynamic stabilization was less with the HES, that's all. I think for theory purpose, you cannot, when you are asked about the evidence, at least you should know the name and at least the significant findings, because you cannot recollect the entire thing about the trial. Your the population, inclusion criteria, everything you cannot remember, but at least the name, what did they compare and what was the outcome. And if you can draw the Kaplan-Meier survival curve or something, no, it shouldn't be exact. It shouldn't be the exact Kaplan. You can show that the control arm is going there and the the treatment arm is there. So that means that there is a mortality difference or something like that. Or you can draw the same forest plot also. It will not be definitely. It will not be exactly as what is shown in the study, but you can convey the message in a easy way rather than writing everything. Okay. So final, no mortality benefit for colloids, increased renal risk, and yes, there is a chance of bleeding manifestations requiring blood transfusion. So as you know, fluid is also a drug. So like drug, we should also consider when to start, when to stop, when to escalate, when to de-escalate, what to give. Okay, the 7 Ds. And out of the 7 Ds, at least you should know drug, dose, duration, de-escalation. Okay, 4 Ds. So what is the definition of fluid overload? These slides you will get from the Fluid Academy. I hope you must have already seen that. IFA, na? Fluid Academy. They have this beautiful these slides. Okay. So what is fluid overload? How will you define fluid overload in daily clinical practice? So why do we daily look at the cumulative fluid balance? What? Yeah, we daily, daily we assess for the if daily we will assess whether there is a net positive or negative balance, and maybe if patient is over 5 days, we will sum up all the previous day's balance, and that is a cumulative fluid balance. So fluid overload is defined as the cumulative fluid balance in liters divided by the patient's body weight into 100. And if that comes above 10%, that means there is an increased chance of mortality. Got it? That is why our concept of resuscitation, de-resuscitation is there, right? Otherwise, we can go on keeping fluids, right? If we are not worried about cumulative balance. So, hypovolemia, everybody knows it is bad. Hypervolemia is equally bad. So, this is the U-shaped curve. So, this is where we want our patient to be. So, what happens when hypervolemia is there? What is the issue if patient is fluid overloaded? Yes, pulmonary edema, lot of, every system will be affected. So, what is happening at the tissue level when fluid overload is there? Permeability കൂടുമ്പോൾ അല്ല അതാണല്ലോ ഫ്ലൂയിഡ് ഓവർലോഡ്. ഓക്കെ, ഇൻഫ്ലമേറ്ററി ഇത് കാരണം capillary permeability is increased, so fluid will extravasate in the interstitium, fluid overload will happen. എന്നിട്ട് എന്ത് സംഭവിക്കും? എങ്ങനെ ഏതാ എങ്ങനെ ഓർഗൻ ഡിസ്ഫങ്ഷൻ? Because you see, this is the blood vessel, this is your interstitium, this is the organ. So your oxygen has to come from this blood vessel to so what happens when there is interstitial edema? The gap increases. See, yeah, fluid is in the interstitium, right? Interstitial edema, the patient always, the size of the patient also increase. So similarly, the size of the interstitium will also increase. So what happens? There is a difference between the cell and blood vessel. The gap increases. So your oxygen will not reach the cell, and the carbon dioxide will not reach the blood vessel. That is how at the cellular level the issues happen. Okay. So that is this diffusion distance. That is the diffusion distance. Okay. Pulmonary edema, intra-abdominal pressure increases, compartment occurs, wound healing decreases, gut motility is affected, and finally mortality is increased. Okay. So you should know when to start fluid, when to stop fluid, when to start fluid removal, and when to stop fluid removal. So for general, the volume of resuscitation fluid, we consider it as 4 ml per kg. We give it over 10 to 15 minutes. Okay. So the question I asked earlier, will the fluid remain intravascular? So if I am giving 1 liter of saline, how much of the fluid will remain intravascular maybe after 4 or 6 hours? I am giving 1 liter saline in a normal patient. Not in a patient. I am giving you 1 liter saline. After 4 or 6 hours, how much of that 1 liter will remain in your intravascular space? Yeah. Any other number? 50%, 20%, 30%, 50%. Okay, it is somewhere around 20 to 30. Okay. So what about dextrose? If I am giving you dextrose, hypotonic fluids, even much less, 10%, it is 10%. Colloids may be somewhere around 90 to 100%. Okay. So this is in a normal human being, where there is no capillary leak, there are no inflammatory mediators. Okay. So what happens when there is a capillary leak? Even this 25% will come down. Okay. That is why your patient may not be fluid responsive. Okay. Again the same thing. So what is fluid creep? Third space, don't forget interstitial. Yes, yes. So you are giving, okay, during rounds you are giving, okay, you are finding the patient needs fluid, you are writing, okay, saline 150 ml per hour. Okay. Is that the only fluid patient is getting? Patient is on vasopressors, triple ion support or double support. That fluid. You are giving meropenem 1 gram TDS, 300 ml plus polymyxin, another 200 ml, 500 ml plus other drugs. So that itself will come to around somewhere around 750 to 100 ml if you measure. Your fentanyl will be there, atracurine will be there, your vasopressors will be there, all the drug dilutions will be there. So we often tend to forget this thing when prescribing fluids because we think, plus if patient is on feed, that also is there. So we often skip this amount of fluids which patient is receiving unknowingly. So always keep an eye on that, calculate that. Then, okay, supplemental fluids you can give. So maybe you can write it as total intake per hour, maybe 150 ml per hour if you need, or 100 ml per hour, rather than NS 150 ml per hour. Okay. Dose. And I told you fluid is also a drug, so stop when fluid is no longer required. Yes. ROS concept. All of you will be familiar with that. R stands for. So what will be the fluid goal in the resuscitation phase? That is when the patient comes to you. Maybe it can be trauma, it can be sepsis or whatever. Resuscitation. What is your priority during the resuscitation phase? Life. We are not looking at the individual organs. We are not looking at the interstitial edema at that point of time. At that point of time, our priority is to maintain the life of the patient. Okay. For that, at that point, we will not look at the fluid balance or anything, or whether patient is going for fluid overload or anything like that. We just give fluids to maintain the intravascular volume status. Okay. That is the initial point. Then maybe after a few days comes the optimization. What is that? That is where we look at the organ rescue. Now we are focusing on, okay, we have stabilized the life, we have filled the pump, intravascular volume status is adequate. Now we are looking at the individual organs, maybe renal, some pre-renal component is there. So we are looking at that, and for that we are giving the fluids. What is the stabilization? Again, moving few days ahead, stabilization. Here we are focusing on we are just giving fluids to maintain the normal function of the organs. So we don't want the kidney to go into another pre-renal failure. So just enough fluids to keep the renal perfusion going on. And finally, at a later point of time, evacuation, because what we gave all along is in the patient's body. So now we have to, everything is settled. Now we have to remove the fluid. Okay, that is the evacuation phase. Organ recovery. Okay. Patient rescue, organ support, organ recovery. How can we evacuate? How will we do the de-resuscitation phase? Evacuation phase. We can aim for a consecutive negative balance. We can go for maybe diuretics, or if patient is on dialysis, we can go for increased ultrafiltrator. Complications of fluid overload. So the question, saline versus balance. Which will you prefer? Balance. Why? Heart rate. Smart or no balanced? Balanced fluids are smart. Or will you reframe the? Will you avoid balance salts? Saline. That is it. This was a debate ongoing for time immemorial, I think. But still, I think there is no definite conclusion, or the conclusion is both are fine. At one point of time, it was like balanced is the way to go. But then again, different trials came, which showed that there is no that much significant difference in mortality between balanced salt solutions and normal saline. So maybe you can use But so what are the trials? Split, Smart AD, then basics, plus, okay. So salted. So what was the acceptable? So I mean, okay, all these trials show that there is not that much difference between saline and balanced salt solution. What was one thing which? Why are you worried about saline? Hyperchloremic acidemia. Yeah. So what will happen when there is hyperchloremic metabolic acidosis? AK, renal afferent vasoconstriction will be there, leading to AK. So that is our concern, right? So what was the one inference from salted trial? Salt ED. Salt ED patients. So they found that, I mean, they used saline, right? They found that up to 2 liters of saline is not problematic in one go. Up to 2 liters, if you give, it is not going to produce your hyperchloremic metabolic acidosis. Okay, if you require more than that, maybe you can think about balanced salt solutions. So we can say that up to 2 liters, it is relatively safe. You can mention anything, saline or balanced salt solution, only thing you have to justify that, no issue. Now, what is fluid responsiveness? Increase in, so my question is, you are using, normally in our daily practice, we are using, how will you assess fluid responsiveness? Normal practice, normal. IVC, fine. Is IVC foolproof? Why? Yes. Okay. Lot of reasons are there. Abdominal mechanical ventilation. The way your ultrasound beam cut the IVC, because IVC it is not that. Yeah, it is not circular. So if you cut at the edges, then your IVC diameter will be less. Okay. Okay. IVC, then pulse pressure variation. So that means BP, right? You are looking at the. But my question is BP a surrogate of fluid responsiveness? Increase in BP is surrogate of fluid responsiveness. So if you are doing PLR, what is the prerequisite for PLR? Yeah. If you are doing a passive leg raising test, the prerequisite is you should have a cardiac output monitor in place. You cannot rely on the BP, that BP was low, you did a PLR and BP improved. That means patient is fluid responsive. BP is not a surrogate of, ideally it is not a surrogate of cardiac output. Why? Because BP can be affected by any sympathetic responses. Okay, even patient will be hypovolemic, but if patient is having pain or anxious, the sympathetic response can keep the BP a bit higher. Okay, so ideally you should have during PLR you should have a cardiac output monitor. So an increase of stroke volume 10 to 15%, sustained increase of stroke volume 10 to 15% after 500 ml of crystalloid over 10 to 15 minutes. So the point is, only at any point of time in any ICU, only 50% of the patients will be fluid responders. So what is our aim in giving fluid? Is it to improve the BP? But we give fluid when BP falls, right? So what is our aim? Yeah, our aim is to improve the cardiac output, preload. So what are the factors determining cardiac output? Stroke volume is there. Oh, no. Stroke volume is not a factor determining cardiac output. Stroke volume is the cardiac output, right? So what are the factors determining stroke volume? Yeah, preload, afterload and contractility. Okay. So when we are giving fluid, we are assuming that your afterload is okay, your contractility is okay. Only preload is deficient. So I am giving the fluid to increase the preload. Finally, it should translate to increased cardiac output. So what is Frank-Starling curve? Yeah, the relationship between stroke volume and ventricular end diastolic volume. That is the preload. So this violet one is the normal heart. If you draw the Frank-Starling curve of your heart, it will be somewhere in this violet. Is it violet there? Yes, violet. Okay. So suppose but we don't know where in this curve the heart lies. So when your patient comes, normal patient comes, not our patient, maybe because our patient most probably won't be in this curve. That's why. So, okay, suppose the patient is here. I am giving a fluid bolus of 500 ml. So, you see the cardiac output has increased this much. So, that means patient is fluid responsive. You will keep on giving fluids. So, what will happen? As you increase the preload, your heart will come here. Now your heart is at this point. Again, at the same point, I gave another 500 ml. So, you see the increase in cardiac output compared to this minimal. So, now the fluid responsiveness has decreased. So, if you again give fluids, it is a plateau phase. Now, most of our patients with a cardiac dysfunction, the Frank-Starling curve will be this one. Okay, this one or maybe even less. Okay, so in such a patient, if you give the same 500 ml fluid, you see the increase is minimal. So, if you increase the further volume, almost negligible increase in cardiac output. So, the volume you are giving is not going beyond the heart. Okay, that is the significance of Frank-Starling curve. So, we don't know where in this point our patient is. That is why we give trial of fluid challenge. Okay, if it is improving, we will just keep on pushing as needed. But if it is not improving, we will not give further fluid. And this is the venous return and right atrial pressure curve. You see, as the venous return, as the preload increase, your right atrial pressure will keep on increasing. Without, and at a point, if you increase the venous return too much, that is, if you increase the preload too much, right atrial pressure increase without any change in the cardiac output or stroke volume. So, because of the capillary leak, we already mentioned. So, this was one study which showed that at 0 hours, around 57% of the patients in ICU were fluid responsive. But as time progressed, by 8 hours, only 3% were fluid responsive. What is this stressed and unstressed volume? Why do we recommend early vasopressors in septic shock? Earlier it was you give fluids, give one fluid, then give vasopressor. But now we say, okay, you can start vasopressors along with the fluids. What is the rationale for that? To maintain the perfusion pressures, okay, that's it. Okay. When those things are there, what is another physiological response? I mean, physiological reason based on this. One reason. Again, say back to the question: what is stressed and unstressed volume? You see, all the blood vessels require some amount of. Think about the reserve in fuel tank. Scooter reserve undallo. Some amount of petrol or fuel will be there as a reserve. Then we will keep it as a reserve. That is known as reserve. Alle? അതിന് മുകളിലാണ് നമ്മൾ ഫർദർ ഫില്ല് ചെയ്തിട്ടാണ് നമ്മളത് യൂസ് ചെയ്യുന്നത്. അതേപോലെ ബ്ലഡ് വെസലിൽ ഒരു certain amount of volume is there to maintain the integrity of the vessel, അല്ലെങ്കിൽ അതിൻ്റെ ആ സ്ട്രക്ചറും ഷേപ്പും മെയിൻറ്റെയിൻ ചെയ്യാൻ ഒരു certain amount of volume വേണം. That is known as the unstressed volume. Okay. So, ഇതിന് മുകളിൽ വരുന്ന വോളിയം മാത്രമേ സ്ട്രോക്ക് വോളിയമായിട്ട് കൺവേർട്ട് ആവത്തുള്ളൂ. ഇതൊരു റിസർവ് ആയിട്ട് അവിടെ നിൽക്കും. വി കനോട്ട് യൂസ് ദിസ് വോളിയം ആസ് സ്ട്രോക്ക് വോളിയം. മനസ്സിലായോ? അപ്പം അൺസ്ട്രെസ് വോളിയം, ദാറ്റ് ഈസ് ദ എമൗണ്ട് ഓഫ് വോളിയം റിക്വയർഡ് ടു മെയിൻറ്റെയിൻ ദ ഇൻറ്റഗ്രിറ്റി ഓഫ് ദ ബ്ലഡ് വെസൽ. ഇറ്റ് വോണ്ട് കോൺട്രിബ്യൂട്ട് ടു സ്ട്രോക്ക് വോളിയം. സോ വാട്ട് ഈസ് above the unstressed volume is known as stress volume, and that is what contributes to your stroke volume. Okay. So what happens in sepsis? What is the pathophysiology in sepsis? Vasodilatation. So vasodilatation means what happens to the vessel? Vessel increase. Stressed volume or unstressed volume? Unstressed, yeah. So your vessel is now big. Earlier vessel was this much, now it is like this. So what happens? Your unstressed volume will increase. So the നേരത്തെ ഉണ്ടായിരുന്ന സ്ട്രെസ്ഡ് വോളിയം പോലും അപ്പോൾ വാസോഡൈലറ്റേഷൻ വന്നപ്പോഴേക്കും അൺസ്ട്രെസ്ഡ് ആയി അല്ലേ? അപ്പോൾ അൺസ്ട്രെസ്ഡ് ആയിട്ട് സപ്പോസ് നേരത്തെ 50 ml അൺസ്ട്രെസ്ഡ് ആയിട്ട് ഉണ്ടായിരുന്നുള്ളൂ. ഇപ്പം സെപ്സിസ് വന്നു, വാസോഡൈലറ്റേഷൻ വന്നപ്പോഴേക്കും അത് മേ ബി 150 ആയി. ഈ 150 എവിടെ നിന്ന് വന്നു? 150ൽ 100 എവിടെ നിന്ന് വന്നു? നേരത്തെ കാർഡിയക് ഔട്ട്പുട്ടിന് കോൺട്രിബ്യൂട്ട് ചെയ്യുന്ന ഫ്ലൂയിഡാണ്. അപ്പോൾ അതെല്ലാം വന്ന് അൺസ്ട്രെസ്ഡ് ആയി, സ്ട്രോക്ക് വോളിയമിന് കോൺട്രിബ്യൂട്ട് ചെയ്യുന്നില്ല അല്ലേ? ഇൻ അതർ വേർഡ്സ് വി വിൽ ഹാവ് ടു ഗീവ് മോർ എമൗണ്ട് ഓഫ് ഫ്ലൂയിഡ്സ് അല്ലേ? നമുക്ക് ആ അൺസ്ട്രെസ് വോളിയമും ഓവർകം ചെയ്തിട്ട് വേണം സ്ട്രോക്ക് വോളിയമായിട്ട് കൺവേർട്ട് ചെയ്ത് പോകാൻ. അതെങ്ങനെ കുറയ്ക്കാം? അപ്പം ഹൗ ക്യാൻ വി റെഡ്യൂസ് ദ റിക്വയർമെൻറ്റ് ഓഫ് ഫ്ലൂയിഡ്സ്? We can use vasopressors. We can reduce the size of the vasculature. So what will happen? The fluid which was in the unstressed volume now will go to the stress volume. That is one reason, okay, for vasopressors. Fluid challenge, you know, we are administering small amount of fluids, maybe 250 ml or 10 minutes. What are we assessing? We are challenging the patient's heart and system, whether they can whether they are responding to that. Fluid bolus means we are giving a large amount of fluid just to increase the intravascular volume. What is fluid tolerance? We are now moving away, or not moving away, but we are also now looking at another point, that is a fluid tolerance. Till now, earlier we used to look at fluid responsiveness only. Whether patient is fluid responsive, we will give fluids. But now there is another concept known as fluid tolerance. Because patient can be at the same time fluid responsive and fluid intolerant. Okay, if you don't look at the fluid tolerance, you will keep on giving the fluids because patient is fluid responsive. So there is a shift from the forward flow to venous congestion. That is the assessing a patient's capacity to handle the fluid expansion without any harm to the organs. So in the early shock state, there is capillary leak, vasodilatation causing hypovolemia. At that point, there is a high tolerance to fluids. Patient will tolerate fluids. Okay, like that is why we don't look at the amount of fluids in the resuscitation phase. In the Rose concept, resuscitation phase, we won't look at how much fluid we have given, whether it is causing any fluid overload or anything. We won't look at. We just keep on keeping fluids because at that point, patient will be fluid tolerant. Now we keep on giving fluids, your interstitium gets filled with fluid. So how will this fluid go back into circulation from the interstitium? Your lymphatics has to drain that. Okay, so in our critically ill patients, the lymphatic drainage will be inadequate because patient is not mobilized, patient is bedridden. So the lymphatic drainage will be minimized and the capacity to drain is exhausted because the volume is beyond the capacity of the lymphatics to drain. Okay, so what will happen? Endothelial glycocalyxal damage will be there, interstitial edema will be there, and what will happen? There will be increased right atrial pressure. You saw that right atrial pressure venous return graph, right? So increased right atrial pressure will be there, leading to different organ failures or organ dysfunction. So in the stabilization phase, there is low tolerance. Okay. Now, how can we assess this fluid tolerance? You know about fluid responsiveness. How can you assess the fluid tolerance? You can look at the Vexus score, you can look at the lung ultrasound, you give a fluid bolus, you look at the increase in B lines, you can look at the echocardiography. Okay. And how can we integrate it into the Rose model? As I said, in the resuscitation phase, patient will be fluid tolerant. You can give large amount of fluids. And again, you can use your ultrasound echo to phenotype the patient. Optimization phase, you have to look for fluid responsiveness as well as fluid tolerance because patient can be both at that phase. Okay, you will have to see for whether there is any signs of congestion even though patient is fluid responsive. In the stabilization phase, when it comes to stabilization phase, patient will move to the fluid intolerant area. So there we can use early vasopressors and minimize the fluids. And finally, the evacuation phase, patient will be fluid what you say, intolerant, completely fluid intolerant. Okay, that is why where we go for evacuation. Okay, so regarding the 30 ml hoax, is 30 ml the standard for everybody, even though the surveying sepsis guidelines say 30 ml per kg? No. From where did this 30 ml come? reverse trial. Okay, then there were another trial, Promise, Erase, the sepsis trilogy. They also used 30 ml, even before randomization, they gave all the patients 30 ml per kg. Then there was another study known as IMPRESS study. IMPRESS study also found that 30 ml per kg is, benefit is there. But there was one issue with the IMPRESS study. They did not individually analyze whether this 30 ml per kg itself is causing the benefit, because they used all the SSC bundles. So it was a bundle approach. Initiation of antibiotics and everything was there. So you don't actually know whether it is the fluids alone which cause the benefit. So again, all this came from the previous understanding of sepsis. It was like, this was the previous, not current. Okay, organ hypovolemia, organ perfusion is there. So you give fluids to increase the organ perfusion, increase cardiac output, and perfusion is restored. But now you know it is not about hypoperfusion only. Sepsis is not about hypoperfusion. Okay, this was the earlier concept. That is why they focused on too much of fluids. Now against the fluid bolus, there were two RCTs which showed that only cold fluid increases the blood pressure. Two RCTs, just because they said that hypothermia triggers the sympathetic system increases the BP. They could achieve the same result as fluid bolus with providing a cooling blanket. Okay, then feast trial, that was in African children, 40 ml per kg saline, albumin, and third arm was no fluid. They found that there was increased mortality in the fluid arm, mainly because of fluid induced cardiac dysfunction. Not fluid overload per se, but fluid induced cardiac dysfunction. Okay. Then you have your classic trial. Classic trial, again, no difference between over and under, restricted and liberal. Clover trial is there. FACT trial in ARDS. Again, the sepsis SSC doesn't mention which weight, 30 ml per kg, ideal body weight, actual body weight, predicted body weight. We don't know. And at that point of time, we don't know the weight of the patient. How will we know? We just, maybe he looks like 70 kg. So we will give 2.1 liters. Okay. We don't know the weight of the patient. We cannot weigh the patient at that point of time in our scenario. Then again, for renal and cardiac patients, your 30 ml per kg won't work. Okay. So 30 ml per kg, our dictum is one size doesn't fit all. We are moving towards phenotyping, individualized, personalized. So how will this 30 ml per kg fit for everybody? That is against our policy, right? And you know the Frank-Starling curve. So intravascular volume depletion, you give patient is fluid responsive, you give fluid bolus, transient improvement fluid, transient improvement cardiac output, BP and everything. Then there will be your leakage of capillary leak and relocation of fluids. Again, your hemodynamics will come down. You will again give fluid, and this cycle will continue till patient is not fluid responsive. Okay. So conclusion: your sepsis trilogy, Process, Arise, and Promise. These trials were the last nail in the coffin of EGDT. Okay. Thank you.
I must say I admire your strength and fortitude after so much of hardcore critical care teaching, still being receptive. All right. So, when I started my DM, my first day I joined my center, me and the patient walked in together. His name was Sarkar, a obese 120 kg guy admitted with severe pancreatitis. Both of us, I walked in, he was wheeled in at the same time. So for about half an hour to 1 hour, I could not report. I was just waiting before I could even say I'm joining now, because everybody was busy with resuscitation. So he was really sick. I learned almost everything in critical care on him. Managing severe pancreatitis, that was a time when we did TPN for pancreatitis. So TPN, obviously he developed ARDS, tracheostomy, difficult weaning, very obese, had a bed sore, improved. At about 2.5 months or so after admission, he from 120 kg, he had come down to maybe around 85-90 kg, and we had done a tracheostomy and switched him over to an NJ tube, and with the, I mean, he had VAP and CRBSI. Again, I learned that on him, and then he improved, and then we shifted him out into a ward. Congratulations all around. So difficult patient, we managed to get him out. 2 days back, he bounces back into ICU. He had a PE because of DVT. Again, in the ICU, developed a VAP. Stayed in the ICU for another few weeks and back. Again, success. 1 week back, 1 week later, he comes in because he had a fall when he tried to take a shower. Had a fracture femur, had surgery. So he was there in, I mean, total of about 6 months from the time, by the time I had almost learned most of the protocols in ICU, and most of them I learned in him. And I kind of kept in touch with him because he has a daughter who is my age, good looking. That was a plus. So he went back to Kolkata, and I know because I was having correspondence with the daughter that, even though we had so-called a success with him, he could have died at any time in the ICU. Probably he tried to die many times in ICU, or else CPR, everything. He cannot take a shower by himself. He could not put a shirt on by himself because he could not button it himself. He was previously a very intelligent man who used to be very socially active and into the arts and all that. He was some kind of a financier or something. Lost interest in all that, became socially kind of reclusive, had depressive effect. It actually made the entire family suffer. So what I know from personally interacting with him and many others is the fact that what we deem to be success or a survival for us is not equal to recovery, and we often forget to look at it from the patients and their families' perspective. And when we look at it, we find that there is a lot that is left unmet, a lot of which we can actually address if we pull our mind to it. So the reason is that because of a lot of changes that has happened, you have a big elderly population, organ transplants, joint replacements, everything increases the quality of life and longevity, and many things in ICU has actually improved the short-term survival. But when you look at the long-term, not survival, but quality of life, it has not really improved. We have a lot of ARDS patients coming. Not all of them die now. You get a lot of them discharged, I mean, at partial functioning, but we don't know how fast they get back to their previous function, or even if they actually even do that. Okay, so we create a lot of people who are not fully functional and suffering. And these disabilities are not very short acting, and they are not to be lasting for up to 8 to 15 years. And some of the psychiatric problems can last even longer. And it takes a toll on not just on the patient, but also the family and caregivers. And a lot of them, even up to 40% of them, actually end up losing their job because of these disabilities. So we should not be so happy that one of our patients, we were able to make them survive and get them out of the ICU, because they go back to a life which is not so rosy and happy. So this is the problem. You have all types of technology, resuscitation, organ support, and we pat ourselves on the back when you somehow make them sort of hemodynamically stable and on minimal supports, and then they can be on the floor or in the ward, and then there finishes our job. Okay, but these patients have a lot of disabilities. The disabilities are mainly classified into 3 domains. You have a physical domain, which is in terms of weaknesses. You have a cognitive domain, which is mainly in terms of taking executive decisions, which they find really, really hard. The things that you and I find easy by just looking at a situation, we know what Even if we don't know exactly what is right, we are able to come to a decision. But for these people whose cognition is difficult because their brain has been affected in ways which we do not yet understand completely, they find it very difficult to make cognitive executive decisions in time, and they have memory problems, they have problems with recall of bad memories, and they have psychiatric impairment as well, and that affects their long-term outcome. So this problem has been identified a long time early. So the first description came in the Society of Critical Care Medicine conference in 2010 when this was discussed, and there was a kind of a consensus agreement, because this is not a disease, because it's kind of a syndrome, just like sepsis or ARDS. Multiple problems can produce this, so it is not a disease but a kind of a syndrome where it is defined as a new or a worsening impairment, either an impairment which was not there before, or there was mild impairment which worsened because of and after a critical illness. So basically in these three primary domains, the physical, cognitive, as well as mental health domains after critical illness, which persists beyond the ICU. So sometimes we see delirium, and that sort of improves within the ICU and they are normal before they are shifted out. That is not PICS. So this is something which persists beyond what we think of as a recovery from critical illness. For us, they look as if they have recovered from critical illness, but these kind of disabilities persist, and that is what PICS is all about. Okay, so again, these are the domains. The physical domain, we all know the ICU acquired weakness. There are neuropathy, myopathy. We discuss whether it is a combination of one or two or both. Very difficult to distinct between the two. So now the term is ICU acquired weakness. Most of the time there is a combination of both. There is muscle deconditioning, not just of skeletal muscles, your diaphragm. A thing which is often underestimated is swallowing problems, and that again further worsens their nutrition and further worsens their ICU acquired weakness and recovery from it. And neuromuscular mobility and coordination is also affected. I don't have to teach you how to look for ICU acquired weakness, right? You know the MRC score and what are the moments that are checked. Okay, so that is the physical domain. In the neurocognitive effect is basically, I told you, the executive decision making which is affected. Other things like attention, especially short-term memory and immediate recall can be affected. Attention span is reduced, and among the mental health problems, depression, anxiety, and post-traumatic stress disorder are the problems. The post-traumatic stress disorder in PICS is distinct from the post-traumatic stress disorder that you see outside of an ICU, because that is usually related to one particular event, right? You had a violent something or some kind of an event, and memories of that actually trigger. And the major way of treating that is what is called a deconditioning therapy. Because it's a single event, it is usually successful if you do it early on, these kind of situations. But in an ICU, the post-traumatic stress disorder is not because of one single event. All right, it is a collection of bizarre, unclear memories which are usually made not in the best level of awareness. When you are in that twilight field between being completely aware and being sedated, and people do things to you which you do not understand, it is usually misinterpreted as assault or battery or nightmares, and you have a very unclear, jumbled up bad memory which is very, very difficult to decondition. All right, so we always talk about the three major domains of PICS, but you must remember that each of them are linked to each other, because let's say depression or anxiety is going to further reduce their mobility and further reduce their physical function. Again, mental again is going to further worsen his the cognition is further inability to actually make tasks. It's going to make them further depressed. It's likewise their drive to actually do rehabilitation can be affected. So each of them are interlinked, and not just that, there is a financial toxicity, and the implications of that is the social implications. The family is affected, not just because of their depression and other things, but also a big financial toxicity, loss of home, reduction of income. Sometimes they have to give up work to be with somebody if there is nobody to care for them. And the impact on family just been termed as a separate entity, which is called PICS-F or PICS family. All right, so now the spectrum is not just the 3 domains, it also includes the social domain as well as the PICS-F. So if you get a question, do not limit it to the 3 domains. You also need to include the social domains and socio-financial probably, and or you can call it socio-economic, and the PICS-F as a part of it. New data is coming up. Okay, so this is, have you heard of the Altos trial? This is follow-up of ARDS patients in US after 6 months and 1 year, and they looked at PIC symptoms, and they found that cognition, impaired physical function, and depression was there in most of them, many of them, nearly 50% of them. And the these are things which we look at in questionnaires and other things, but the one thing, especially following COVID, is the finding that there is this unexplained fatigue, which by itself is a very prevalent new symptom, and unexplained pain. These are again increasingly being recognized as component of PIC syndrome. So in addition to the cognitive, psychiatric and physical problems that we said, these are things which many people without empathy and without an understanding of what they really went through, generalized weakness, how much importance do we give it to? I mean, it is something which you would sort of not give too much importance, but it's something that these people are really suffering from. And vague pains which are kind of diffuse everywhere, you cannot diagnose it. Again, we tend to sort of ignore it or underplay that. So, but for the patients, it's real. You need to know the common differential diagnosis. One of the common differential diagnoses you need to think about is GBS, because if it is ICU acquired weakness, which you kind of see it in the ICU sometimes, especially in the acute phase, especially they come with a, let's say, a fever or some kind of a thing, and they, as you take them out of the ventilator or take them off sedation, then you see that they have weakness. It could be ICU acquired weakness, or it could be, so that is a differential that sometimes you have to think about, but you need to look at the clinical presentation, and the timeline and the diagnostic tests are not going to tell you exactly what is what, because the distinction is basically clinical. Okay, coming to the risk factors, a lot of risk factors are there. So it depends a lot on what type of admission it was. The patients who got into ICU for elective complicated surgery would have less PICS compared to somebody who had an unplanned surgery, who will have less compared to somebody who had a medical problem like septic shock or ARDS. Okay, it depends on the ICU length of stay, it depends on the severity of illness, it depends on the type of treatments that they received. Okay, so the more they were ventilated, the more they had vasopressors, the different types of organ supports they had, all of them kind of makes it more likely that they will develop PICS. But among the treatments, you need to remember that there are some other things which are under our control. The degree of sedation, the choice of sedation, use of steroids, inotropic drugs. Again, I would say there is a choice, because many of us are guilty of not tapering them as fast as we can, because they are not without problems, because they also contribute to ICU acquired weakness. The personality traits and previous mentation and personality and psychiatric diseases do contribute. So somebody had depression earlier, there is a very, very high chance that they will be depressed after critical illness. Obesity and other things are there, and there are non-modifiable things. Unfortunately, female sex are more vulnerable to PICS. The younger you are, the more likely you are to develop PICS, and unemployment also contributes to a higher risk of PICS, so lack of social support. So you can modify the risk factors as not modifiable, potentially modifiable, and modifiable, and focus on the modifiable part of it, because sedation use, preventing delirium in the ICU, mobilizing them as early as you can, allowing them to sleep. This is something which we very seldom give any attention to, because they will, in my ICU, my nurses will start their rounds of morning care at 3 o'clock, X-ray will start their rounds at 4 o'clock, then they will start a round of venesection to collect blood. So the time when you and I would have their best sleep, these patients who cannot sleep at best because of different problems, and then because of lights and monitors and sounds, are not allowed to sleep. So hyperglycemia, negative memories of ICU, these are things we can avoid. And there are things which can actually, there are many things which can actually do to improve that. Orientation to time, having a clock, having mirrors so they can see what they look like, having visitors come and talk to them. All these kind of will improve their perception of how they are, their perception of a kind of autonomy that they still have, and all that will improve their ICU experience and reduce the instance of PIC syndrome. Okay, so this is a paper again from the Altos paper, post ARDS follow-up 6 months and 1 year in US. This is not Altos, this is another paper, this is from Netherlands. So this, if you look at elective surgery, you have the least instance of total PIC syndrome compared to urgent surgery, and medical diagnosis had a highest instance of PIC syndrome. So the reason why they got into the ICU seems to have a bearing on whether they are going to develop this or not. The exact pathophysiology is not very clear. Many people blame the inflammatory cascade, which is unregulated, the inflammation and thrombotic cascade, which, I mean, if anybody asks you about pathogenesis of sepsis or ARDS or things like that, that's what we think about, and that's what most of us did think about PICS as well, but it does not seem to be completely correlated with that. Okay, so this is the ARTSNet follow-up study that I was talking about. So big paper. So what they found is that the physical and mental impairment that the patients developed, for example, ICU-acquired weakness or the cognitive the depression kind of mental health issues that they had, contributed to the severity of illness. I mean, it correlated with the severity of illness, but the cognitive impairment was not directly linked to the severity of illness. So all of these components of PICS are not correlating directly with the severity of illness, and probably there are different mechanistic reasons why each of them appear, and which is not really very clear. So the severity of illness is one risk factor, but does not completely explain all of them, especially the cognitive domain. What about the degree of inflammation? This is a very nice paper which came in the Blue Journal. So they looked at different markers of inflammation on the coagulation cascade and found that for tests of cognition as well as for tests for mental health, none of these markers were correlative or predictive at the peak markers at when they were in the ICU and the follow-up markers at 6 months old. So inflammation and the unregulated inflammatory response may contribute, but the severity of that alone does not explain either the incidence of PICS or the severity of PICS. This is a look at basically the psychiatric symptoms. So again, the finding is that the severity of illness, the number of organ failures, the degree of vasopressor use was not associated with psychiatric symptoms. Okay, so there is what exactly is the pathophysiology? If you ask me, I don't know. Nobody seems to know as of now, but all of these seems to contribute, but no one single thing seems to be determinant of this. Okay, and for the psychiatric component, at least the single most predictive factor which determines if they are going to have the psychiatric domain of pigs is a negative experience in the ICU. Okay, so if your patient develops delirium, they are very likely to develop these symptoms. So if you extend it further, if you could prevent the development of delirium, you could prevent the development of this. So again, this is not proved by evidence because we do not have randomized control trials looking at long-term outcomes like this in ICU. There are some trials which are starting, but we don't have evidence for any of these interventions that I'm going to talk about now because they are all based on just a physiological logic and a wishful thinking and small case reports and case series. We don't have a grade 1 evidence that any of the things that I'm going to talk about next are going to work. But what are the things which are possible? You have all heard of this, the A, B, C, D, E, F. Now we have G also, D, H also, all right. So have you seen that? You have seen that. I think the A, B, C, D, E part, most of you have seen. Okay, so we have good evidence that managing pain is good. The PAD bundles, we have great evidence that if pain is there, it should be managed and it should be the ideal drugs for pain management. We know SAT and SBT, we now have good evidence. Choice of analgesia and sedation, we now know. But yes, time. All right. So, all right. Okay, I think till here we have evidence, but when we come to mobility, there is a conflict. You know, there is one RCT at least which showed harm when there was early mobilization, but more and more, if you look at the case reports also and the case series, there is overwhelmingly evidence of benefit. Family engagement, good communication, handout materials, there are small papers which tells you that there is a benefit. If you look at the empowerment, it was, I don't know whether it was an intentional typo. I just cut and paste it from somewhere else. Probably it was intentional because POW therapy is now increasingly being used in many ICUs and it seems to reduce delirium and have instead of a negative vibe, many patients develop a positive vibe. Okay, so these are cleared by their infection control. I'm not joking. So, okay, coming to the ICU diary part of it. So the ICU diary can either be maintained by the healthcare workers, the staff who is looking after the patient, or by the patient relative. The idea is that they will give the patient, once they are better, a better idea of what they went through, so their memories can be arranged and sort of made sense of. It must be, I want you to be aware of these two papers from AIIMS Bhubaneswar. If you look for ICU diaries and their effect evidence, these papers pop up from India. But the problem with diaries is that the intention is to reduce the PTSD because that recall and other things, if you have a better idea of what really was going on. But again, it can be a double-edged weapon. In somebody who had no recollection of their ICU, you show that diary and when you can actually, so I mean, I'm not joking, there are reports that this has happened. So maybe it may be a tool if it used in the right time. Okay, the timing at which it is divulged or shown to the patient is also important. Okay, so these are the different types of interventions which have been studied. I think let me go a little faster now. Okay, so you need to identify patients who are at risk for developing PICS. So the conventional cutoff is any patient who requires more than 2 days of mechanical ventilation, a high Apache score, and anybody who requires tracheostomy. By default, they have to have a follow-up. Also, patients who had delirium in the ICU or patients who show already features of PICS like cognitive impairment or mental health impairment or ICU acute weakness, they should be selected and they should be followed up in the ICU and they should be provided this kind of care. So again, when we come to care, the first thing that I need to stress is the polypharmacy has to be avoided because they would have been seen by multiple specialists, each of them independently ordering different medications. So I mean, we do see, not just all of you must see a patient who is on 2 or 3 PPIs, 3 types of ARB sometimes. So because one person does not know what the other person is, so a little bit of coordination by one person looking at all the medications, cutting out whatever is unnecessary. Another thing is BP optimization, because if whatever has been done, again just like sugar, whatever has been optimized while the patient is in ICU needs to be re-optimized as they become more mobile and they return to their lifestyle activities. And you also do things like smoking and alcoholism cessation and management of their healthcare plans. Okay, so there are different ways of screening for disabilities in each domain, and this, I think you need to read this paper by in IJCCM, the ISCCM position paper on PICS and management. So these are the tools that they describe for screening and assessing PICS. So you assess different domains like psychological, cognitive, physical, functional, quality of life, and also the respiratory status and nutritional status. And you provide, once you detect any of these abnormalities, they provided counseling in terms of debriefing what happened, telling them what was really the problem and what was done for that, and discuss the prognosis, and also in discussion with them find out what is the thing that is most affecting them. So for you it may be a problem that their 6-minute walk test is distance or say desaturation is really, but for them it may not, maybe a inability to sleep. So the patient priority of their problem should tell you what would be your priority which need to be focusing on, and you have to set realistic goals and provide appropriate, because it has to be a multidisciplinary care, different specialists have to be there, and you provide physical strengthening exercises, nutritional support, speech swallowing support, cognitive therapies, and psychological support for those who require them. Okay, so for the PICS clinics, ideally are recommended to be directed by an ICU specialist because they know what the patient has gone through and they know what is expected, and they can sort of like an orchestra conductor harmonize the different specialists who are involved in providing this kind of a care. And all of these things, unless you pay attention, like providing mobility devices, the fall alert devices, there are smartwatches which will actually help you without too much cost. So these things are available, and I think as you do have a fiduciary duty to our patients to let them know that these things are available and that can help. And last, I'll conclude by saying this is PICS family. I've already told you what it is. So this is, it can be in the family, it can be any caregiver who cares for the patient, and it is much more when you have a pediatric patient who is involved. For a pediatric patient who is involved, you would think of PICS family affecting the parents, but be aware that it can affect the siblings also, because you know, children, they look at how attention of parents get devoted to another, and it can be traumatic for the other child as well. So we generally tend to ignore the other sibling as part of PICS when we think about pediatric PICS, but that is a big problem that need to be addressed. Thank you. Any questions?
Any questions? Any questions? I think it's an important concept, and I think I do expect a question on that. for the theory exams. Let's see what. If there are no other questions, I would like to thank Jojo sir for taking out and being here as a token of appreciation.